Good morning, everyone. Welcome to Medical Dermatology Therapy Update number 3. For those of you who have been here in the past, you'll recognize that we are in a completely different part of the convention center. So I'm glad you were all able to make your way down here. I know if you came in through the front by the Marriott Hotel, it was quite a walk. But if you did come in through that door, you also recognize that they're doing construction in the area where we usually have this conference, and we'll hopefully be back there in 2 years for our Medical Dermatology Therapy Update 4. Before we begin, I'd like to say a special thank you to our grantors, Janssen Scientific Affairs, Novartis Pharmaceuticals Corporation, Pfizer, and Sun Pharmaceutical Industries Incorporated. And please, during the refreshment breaks, please take time to visit some of the 35 exhibit tables that are set up outside between the grantors and our exhibitors. They are vital to being able to fund this conference and to put it on every other year. Today for lunch, I just want to let you know that there are 2 optional non-CME satellite product theaters. These will be offered from 12:10 p.m. to 12:50 p.m. The lunch will be available in the lobby, and then you can proceed to one of the satellite rooms. Amgen will be having their satellite theater in 25AB, and UCB will be having a product theater in room 25C. And thank you for supporting these programs. Again, they help fund this entire course. Our faculty presentations are available on the Showcase website. Instructions are posted on the online program guide and the slides. The American Board of Internal Medicine, MOC, and American Board of Dermatology continuing certification credits are available for this course. Pre-registration for the American Board of Dermatology is required. If you are interested, please stop at the registration desk by noon on Friday to figure out how to register for that. For evaluations and CME certificates of participation, as well as MOC, we will email you when credit claiming is open. And please take a few minutes when you get that email and on your paper evaluation to complete those forms, because we do look at your responses and we do rely on your feedback in terms of planning our next course. And with that, I'd like to begin. Our first speaker for this morning is Dr. Adam Brown. Dr. Brown is a staff physician in rheumatology here at the Cleveland Clinic. Dr. Brown is board certified in internal medicine and rheumatology, and he then did special training in vasculitis. Dr. Brown is the moderator for the podcast Ruminations, which he has been moderating for about 6 years, and I would encourage you all to listen to that. Adam is a fantastic moderator, and the education is fantastic, and also just great entertainment and conversations. And we also, because of how good he is at Ruminations, roped him into being a moderator for the Cleveland Clinic Journal of Medicine's Beyond the Pages podcast, which you can also find wherever you find your typical podcasts. And he's also the author of Rheumatology Made Ridiculously Simple. And he's going to talk to us this morning about updates in the treatment of cutaneous vasculitis. Dr. Brown.
Thank you. Forward, backwards, labeled. That's very nice. All right. See if this works. All right, cool. All right. Thanks for having me here. I'm very excited to be here. I have, as he mentioned, as Dr. Fernandez mentioned, I have an interest in vasculitis. I did an additional year of training in it. We see quite a bit of it at the Cleveland Clinic. And, you know, as we probably all know, vasculitis comes in many walks of life, right? People kind of think of it as kind of this broad diagnosis of vasculitis, but it's really not. It's kind of the downstream process of multiple different pathologic processes. And I'm going to try and talk about kind of the overview about cutaneous vasculitis. And I won't be able to get to all of it, understandably, in 30 minutes, but I think that I've kind of hit some high points that I think are really, really important. And then I'm going to kind of focus a little bit on kind of understanding is it a systemic process or not, because that could really kind of guide workup and management in these patients. So in an overview, I'm going to talk about the anatomy of the skin and the vessels we're talking about primarily. Then I'm going to give an overview of cutaneous vasculitis, focusing on leukocytoclastic vasculitis and palpable purpura and small vessel disease. Then I'm going to go to causes, and then I'm going to focus a while on whether or not this patient may have systemic manifestations and what kind of clues can be gained in the clinic fairly easily. You can kind of just ask a couple questions and then also do some things on exam that could really make a difference on catching this patient, hopefully before their disease progresses potentially very rapidly. And then talk about workup approaches, and then in the end, I'll talk about treatment, and then some kind of exciting future trial designs and how hopefully that'll help us guide management in the future for cutaneous vasculitis. As right now, as you can probably guess, it's a bit of a guessing game when initiating certain therapeutics for limited cutaneous vasculitis. Systemic vasculitis is a different beast altogether. There's a little bit more rigid guidelines on how to manage these patients, but limited cutaneous is not so much yet. So when I mention vasculitis, what exactly am I referring to? Patients come in, or people ask me all the time, like, I have this kind of I can see my vein really prominently. Is it vasculitis? I think there's kind of this broad idea of what vasculitis is. So vasculitis is rare. It's not very common, and it is primarily looking at the autoimmune inflammation of the blood vessels. So when I talk to patients, I'm always saying, well, when autoimmune is like when your immune system is, it's built to fight off bacteria and viruses and keep you healthy. But for reasons we don't understand, often it goes haywire a little bit and it starts misfiring, right? And in rheumatoid arthritis, for example, it can misfire and kind of attack the joints and cause big swollen joints and painful swelling. But in vasculitis, instead of the joints, it's attacking the blood vessels. And when that happens, it can lead to a couple different complications. So in small vessels, for example, it can lead to kind of the endothelial lining of the blood vessels being not working as well and allows red blood cells to extravasate out of the vessels. In larger vessels, it could lead to weakness of the wall of the blood vessel, and it can kind of lead to aneurysm formation. Or it could lead to where the blood vessel is so inflamed, the walls kind of narrow and the lumen narrows and narrows, where it leads to downstream ischemia. So it can do a lot of different things, which makes the presentation varied, right? It's not just one thing that vasculitis can do, and there's also multiple extravascular manifestations of vasculitis in certain cases, which keeps you on your toes, right? So vasculitis is a broad term, but in every vasculitis lecture across the globe, we have to have this slide. It's mandated. I'm just kidding. So we always talk about the different blood vessels, looking at the different sizes, and that's how we kind of categorize vasculitis. And is the blood vessel inflammation happening in the large vessels, where we think of probably the more common vasculitis called giant cell arteritis, and happening in people above the age of 50. Or in young people, it's called Takayasu. It's a little bit different, but it's still large vessel vasculitis. Then we get the medium vessel vasculitis like polyarteritis nodosum, which is very rare now. When I was in medical school, I assumed this disease was going to be very common because they always had abdominal pain and they did an angiogram and they had tons of little aneurysms, like, oh, this is polyarteritis nodosum associated with hepatitis B. But now we have hepatitis B vaccines, so this diagnosis is exceedingly rare, although we still see cutaneous polyarteritis nodosum, which I'll talk about very briefly. So then we have the small vessel vasculitides, and this is where there's a lot of different types. There's ANCA vasculitis, you've probably heard of, IgA vasculitis, cryoglomerulonemic vasculitis, and urticarial vasculitis. And this is primarily the small vessels, where it can involve the skin, but it can also involve the lungs and the kidney in many of these diseases. So it's really important to monitor for these patients if they have any kidney involvement or any lung involvement. These diseases are, not a lot of things in rheumatology are rapidly fatal, but vasculitis can be. So it's one of these diseases you want to catch as soon as you can, if there's systemic involvement, or is it just in the skin. And whether or not it's associated with one of these systemic processes like ANCA vasculitis or IgA. So most of the leukocytoclastic vasculitis I'm talking about is going to fall into the small vessel vasculitis. So I thought it'd be kind of as I was doing this talk, I was like, am I really going to be a rheumatologist who talks to a whole room of dermatologists about skin anatomy? And I was like, hey, there's the epidermis and the dermis. Can you believe it? Right? But it's important to kind of recognize where I'm talking about most of the blood vessels involvement, and it's primarily in the small blood vessels in the dermis that lead to kind of this inflammation, and that allows the red blood cells to extravasate out of the vessels and lead to what's called palpable purpura, which is one of the most common presentations of leukocytoclastic vasculitis. Whereas the median vessels, a little bit deeper, are more associated with other conditions like cutaneous polyarteritis nodosum, which you often can miss on a punch biopsy, but they present very differently. When the vessels are deeper, the presentation is not nearly as like a discrete little lesion like we see in palpable purpura. It can be kind of more livido and less well defined when the vessels are deeper. And that usually kind of prompts an incisional biopsy. But by far and away more commonly is what we see as palpable purpura and small vessel involvement. So this is what I'm talking about. So you have these lesions throughout the skin. It's often in the lower extremities of buttocks or the quote-unquote dependent areas where you can get kind of neutrophilic death, neutrophilic extravasation, and kind of red blood cell extravasation out of the vessels within the dermis, which can lead to this palpable purpura, and that's non-blanching when you push on it because the red blood cells are out of the vessels. And when you push on them, they have nowhere else to go because they're not within the vessels. So non-blanching palpable purpura, you see it, and it looks a whole lot like what quote-unquote palpable purpura. So let's give a quick overview. So leukocytoclastic vasculitis is the result of pathophysiologic processes common to different causes. This is a really important point because when you see a patient with palpable purpura, you're like, oh, I think this is probably vasculitis or small vessel vasculitis and leukocytoclastic vasculitis. I think that if we biopsy it, we'll make a diagnosis. It's not really a diagnosis though, right? It's just kind of a hint of maybe something else going on, because there's so many different processes that can lead downstream to that diagnosis. So it's really important to recognize once you have that diagnosis, once you have that finding of leukocytoclastic vasculitis, what is the cause, or can you find the cause? Spoiler, 50% of the cases you can't find a cause, it's idiopathic. But it's important to kind of recognize what you can and what you can't find. That could really guide workup and really guide management going forward. Lesions are typically dozens to hundreds. They're polymorphic, typically appear on dependent areas like legs or buttocks, and about 30 to 60%, depending on what trial you're looking at or what cohort of LCV is limited to the skin. So you can say around 50% of the time it's just in the skin, and hopefully it's going to be self-limited in many of these cases. But I want to emphasize the point that there's a lot of different processes that can lead to the finding of palpable purpura, and the job is to try and figure out what that process is. And let's start with a case here. Well, it's not really a case, it's a historical vignette, really. So, Alfred Reinhardt from 1931. So, this is a case of a young man who was a medical student at Harvard in the 1930s, in his 20s at the time. And this young man had a history of rheumatic fever, which is very common at the time. And he had this history when he was when he was 13 years old. Now he's in his 20s. So since that rheumatic fever, he had severe aortic insufficiency. His valve was compromised. And he actually said he could feel every heartbeat that he had based on the wide pulse pressure. And he said throughout most of his life, they would kind of feel his heartbeat because of the severe aortic insufficiency. Apparently, he didn't think a whole lot of it. Rheumatic fever was very common. But when he started medical school, he started learning more about the complications that can arise from severe valvular disease. And he learned a couple things. One of them being that he could develop heart failure. And he's like, oh, wow, this is really, I got to kind of pay attention to this. This could be very bad. The other one is that he is a higher risk for developing endocarditis whenever he had valvular disease. So during the second or third year of his training, he started feeling worse, started having more fatigue, he started having episodic fevers, and he went to a doctor, a cardiologist, and said, I'm not feeling well, I'm worried I have endocarditis because I learned about this. And the doctor's like, all the medical students think they have everything, right, that they learn about. So they blew him off, said it's probably a recurrence of your rheumatic fever, he probably had a strep infection. So he said, okay, hopefully this is it, hopefully I'm all right. So then said he's getting ready for school one day, and he said, no sooner had I removed the left arm of my coat than there was on the ventral aspect of the left wrist a sight which I shall never forget until I die. There greeted my eyes about 15 or 20 bright red, slightly raised hemorrhagic spots, about 1 millimeter in diameter, which stood defiant, as if they were challenging the very gods of Olympus. I took the one glance at the pretty little collection of spots and calmly said, I shall be dead within 6 months. So was he describing petechiae or was he describing palpable purpura? I'm not sure, but I think it was pretty incredible reading his story, like how like the skin manifestations were like, this is what I have. Like he just knew it right away. He had endocarditis. And he was absolutely right. He died 5.5 months later. The interesting thing, one of the impressive things about this Mr. Reinhardt was that he like documented everything. He actually refused pain medications despite having a splenic infarct and having a stroke from the endocarditis later on, because he wanted to document it to help medicine understand what patients go through with endocarditis. And he documented his whole story until 2 days before he died. So, so endocarditis is one of the things in rheumatology, at least, that we're extremely aware of, and I think that it's one of the diagnoses that can very easily be missed. And if it's missed, it can be catastrophic in these patients because it can do a whole lot of different things, including leukocytoclastic vasculitis. And I'll get to it in a little bit, but they can also have a range of autoimmune serologies, ANCA positivity, ANA positivity, low complements, that can kind of push you on this pathway of an underlying autoimmune process, when in fact they have a big vegetation on their valve, and then you give them rituximab or something aggressively immunosuppressive, and it can lead to the patient dying. So we've had a lot of, in the hospital especially, we've seen a lot of patients with, leukocytoclastic vasculitis, and rheumatology gets involved. They're eventually diagnosed with endocarditis. It's one of those big things that it could be a very bad miss to miss endocarditis, so we're very aware to watch for it. So, what are the chances of these patients having palpable purpura? Well, if you look at Harrison's Principles of Internal Medicine, it's not even listed on here. But one thing that was surprising, again, one of the fun facts about medical school is when you learn about the stigmata of endocarditis. You have Janeway lesions, you have Osler nodes, you have all these things like which one is painful, which one's not in the hand, trying to memorize that. You have raw spots in the eye. All these things you're looking for on patients when you suspect endocarditis. But putting all that together, just one of those findings is less than 10% of patients with endocarditis. I remember I had a resident, and I was like, well, this patient was seen. Any chance the patient had endocarditis? Like, no, they don't have any Osler nodes. Like, okay, so it's probably it's not synonymous with endocarditis. Most patients do not have any of those findings. Okay, by far and away the most common manifestation from the cutaneous aspect is petechiae. Okay, which may be what Reinhardt was describing. I'm not sure. Splenomegaly is common, anemia is common, glomerulonephritis in almost 50% of cases. So you can see that these patients could be kind of missed because they have leukocytoclastic vasculitis, they have glomerulonephritis, and they think, and they may have an ANCA positivity. So there's a lot of things that you kind of have to watch for with endocarditis. So what about LCV in endocarditis? A study from 2015 looked at 766 cutaneous vasculitis patients. 26 of these patients were found to have underlying infection, and 6 out of the 26 were found to have infectious endocarditis. So not a whole lot, right? Let's look the other way. If you have endocarditis, what are the chances you'll have leukocytoclastic vasculitis? A retrospective trial looked at 4 out of 100 patients with endocarditis had palpable purpura or leukocytoclastic vasculitis. I think that's sort of telling that if you're seeing even a couple dozen of patients a year with LCV, you're probably going to come across a patient or two with endocarditis, right, presenting with it. And the one thing that is, I think, important to recognize is a lot of patients aren't necessarily really ill appearing. They can have kind of fluctuating symptoms, they can have fevers, they can have fatigue. Over 10% of patients don't even have fevers. That's usually the subacute type of endocarditis. The acute endocarditis is usually what we think about when they're really sick, they're feverish, they have a stroke, they have a splenic infarct. But lots of patients, that's not usually a diagnostic dilemma. The diagnostic dilemma are these subacute patients who kind of wax and wane over time, and they can present with these lesions, and someone works them up and they have kidney disease, and that's how they kind of go down the pathway of an underlying autoimmune process. So now let's switch gears and primarily focus on palpable purpura. And so what are the overall causes of patients with palpable purpura? So there's a couple different categories, and they're all sort of equal in things that can cause it. Infection, about 20%. So not necessarily, again, endocarditis isn't the most common cause, right? But it's one of the things that you don't want to miss it because it's very, very critical to make that diagnosis. So 20% of patients are infections in general, which is there's a laundry list. I didn't put up this list because it's kind of boring to see it because it's like, okay, rubiola, all sorts of viruses can cause these infections. URI is most common. I see that a lot. A patient has, congestion, cough for a few weeks, then that resolved, and all of a sudden they have these lesions on their leg. So I see a lot of these patients coming in with the LCV responding to the URI. Drug reactions, vaccine, about 10 to 20% of patients. So often the kind of rule of thumb is if they started the drug within 7 to 21 days of the initial outbreak of the lesion, then it could be possibly drug related. Then we get to underlying autoimmune disease process, 10 to 20%. So that's very broad. So autoimmune disease process, what are the different autoimmune diseases that can do that? And I'll kind of highlight that in a little bit. Malignancy, 5%. I don't think I've come across a patient that was diagnosed with palpable purpura and was found to have underlying malignancy, but it's fairly rare, but it can happen. And then we have idiopathic. Nearly half of patients can be considered idiopathic, meaning we have no clear cause of the disease. But in rheumatology, that's a pretty good number. I'd probably say most of my diseases, we have no idea what caused them. So 50%, we're getting somewhere here. But so let's get to so the infection, what do we look for? So more commonly, upper respiratory tract infection can do it. Parvovirus can do it. Again, there's a long list of viruses that can do this, but there's not a whole lot to do about most of them, right? So lots of the cases, the patient may have had a clear infection, viral prodrome, and then they develop these skin lesions. And okay, so there's not a whole lot to do about the infection itself. But then you don't want to miss are hepatitis B and hepatitis C, and those can both lead to cryoglobulinemia. And those cryoglobulinemia can lead to immune complexes and cryoglobulin deposition and palpable purpura. So those are the big ones to check for whenever I see a patient with leukocytoclastic vasculitis, hepatitis B, hepatitis C, and is there any evidence this patient could have endocarditis? Because that could change exactly what you do very quickly, right? So again, just to emphasize, these patients can have a lot of different things. They could have 30% of patients have cryos, depending on the organism, up to like 70% can have ANCA positivity and endocarditis. Often they have low complements, so it can be a very mixed picture when you're not thinking about endocarditis, and you can easily go down the pathway of an underlying autoimmune process. Drug-induced, 20% of all cases. So what are the most common drugs? Again, one of those things where you just list a whole lot of things, but I think the easy thing about this is like, did you recently start a drug? Did you recently start a drug before all this happened? But other things can do it, and it can be trickier if you've been on the drug for a long time and all of a sudden you have a response to it, but beta-lactams, NSAIDs are on there. I was surprised NSAIDs is so high on the list because I feel like I give NSAIDs a lot, and I haven't really come across this being a problem. But that's the data. NSAIDs are up on the list, but look at the actual total. This is kind of a more comprehensive look at the drug, so take some time to memorize all this. But I think the point is, did they recently start a drug? And importantly, that could absolutely change what you do, right? Because then hopefully the patient doesn't need a whole aggressive medications. They could just stop the drug, stop the offending drug, and hopefully the lesions will resolve. So then vaccines, right? This is just because fresh on people's mind is, COVID vaccine, could this be associated with it? And there's plenty of case reports of COVID vaccine potentially triggering leukocytoclastic vasculitis, but there's a whole lot of case reports of pretty much all the vaccines doing that, right? So if you look hard enough, you can find it. There's no evidence that COVID has a higher risk of developing leukocytoclastic vasculitis, but there is case reports of it. I talk to patients, like whenever you put something in your body that there's a potential that it can, spark an immune response. So whether or not it's a new medication, whether or not it's a vaccine, it can happen. So these patients can get a vaccine and a few days later, or even 10 days, 14 days later, develop palpable purpura on the lower extremities. Again, hopefully recognizing that's really critical because you know that hopefully this is going to go away, right? You're not having a continued insult that's going to hopefully not perpetuate this disease, and hopefully it'll be self-limited. So now we get to autoimmune diseases, which is a bit more broad, right? So a lot of different things a lot of different small vessel vasculitides can be associated with leukocytoclastic vasculitis. And I'll kind of get to how do you find hints of that going on in the next slide. So ANCA vasculitis. So microscopic polyangiitis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis. So those are three of the ANCA vasculitides. Most patients with eosinophilic granulomatosis with polyangiitis are ANCA negative, so a little bit harder to diagnose, but they have high eosinophils, and they often have a history of asthma that usually gives a clue to the underlying diagnosis. So ANCA vasculitis is pretty common to have leukocytoclastic vasculitis, and it can also be the presenting sign. It can have very ulcerative disease. It could be pretty severe in the minority of cases. Then you have IgA vasculitis, which could be the time that I think immunofluorescent staining on skin biopsy is useful to evaluate for IgA deposition, predominant IgA deposition, because I can give a clue that you got to watch these patients' kidneys a little bit more, and I can also give you a diagnosis of IgA vasculitis. So often the other times, like in ANCA vasculitis, it's not going to say, oh, this leukocytoclastic vasculitis is consistent with ANCA vasculitis. It's just going to say leukocytoclastic vasculitis. So it's going to be very broad. It's not going to give you what's causing it again. Then we get cryoglobulinic vasculitis. So from an autoimmune standpoint, it's by far and away more commonly associated with Sjogren's syndrome and a little bit secondary with lupus. But in Sjogren's syndrome, interestingly, it's often early on in the diagnosis. So patients may not be aware they have Sjogren's syndrome. We've had a few patients coming in with leukocytoclastic vasculitis, with glomerulonephritis. We would check their cryoglobulins, they're sky high, and their C3 and C4 are low. And then, on history, like, oh, yeah, I have dry mouth, but it's not a big deal. And then we check them, they have SSA positive. So they may not know they have Sjogren's by the time they present. But that could be the presenting diagnosis, presentation with palpable purpura. Then rheumatoid vasculitis. We get asked about this. We get asked about this a lot. It's pretty rare. And it's rare, not because it doesn't happen in rheumatoid, but most patients are totally treated with rheumatoid arthritis. So, 30, 40 years ago, when we had a lot less management options in patients with rheumatoid arthritis, you saw rheumatoid vasculitis a whole lot more commonly. So typically in rheumatoid vasculitis, it's medium small vessel disease. It can lead to palpable purpura. It can lead to nerve involvement as well. But it is by far and away most common in patients with very long-standing rheumatoid arthritis, untreated rheumatoid arthritis. So I've seen it a few times in patients who, for whatever reason, have not wanted to be on any medications, and they've had the disease for 20, 30 years, and they had severe deformities. It's not usually a mystery diagnosis at that point, because they can't move their joints. Their rheumatoid is so bad. So it's typically in patients with very, very long-standing rheumatoid arthritis, which, again, you don't see very often anymore, thankfully, because we have such good therapeutics. But we see it a couple times in patients with long-standing disease that are untreated for whatever reason. So how do you work up systemic involvement? So there is things you can kind of ask for. So, most of these cases here, these patients can have systemic involvement in any of the drug-induced or vaccine-induced, whatever it is, but in systemic autoimmune disease, that's kind of the big concern, is they have systemic involvement that's going to dramatically change workups and dramatically change therapeutics. So what can you do? So you kind of go down the list, right? So, arthralgias, these patients have new onset joint pain associated with the leukocytoclastic vasculitis, and it's usually not subtle. Usually like, oh yeah, I'm really stiff in the morning. I have a hard time getting up and moving ever since I've had this rash. It's not usually like, oh yeah, my knee bothers me when I go up the stairs sometimes. Is that it? No, probably not, right? It's usually kind of a new onset of joint pain that's very unfamiliar to the patient. Sinus symptoms. So that's an important one to ask for because patients often do not equate that with their rash, right? Where it's highly associated with granulomatosis with polyangiitis or GPA because patients think sinus disease is common. And they could have kind of severe congestion in the sinuses for often months leading up to the diagnosis. And they get antibiotics, that doesn't help. They get another round of antibiotics, doesn't help. Maybe they get some steroids and it helps clears up the sinuses. So that sinus disease can be directly associated with that rash. So it's important to ask about it because that, again, prompts you to order ANCA testing. These patients might have granulomatosis with polyangiitis or GPA. So sinus disease is kind of a big concern for underlying ANCA vasculitis. So pulmonary manifestations, this can be subtle, okay? So we think about, vasculitis where the red blood cells kind of extravasating out of the vessels, and that can happen in the lungs. It can happen in the skin, which can leave a rash. But what happens in the lungs, that becomes a big problem, right? That definitely leads to poor oxygenation because their lungs, alveoli get full of blood. So it's called diffuse alveolar hemorrhage. So, you think about these patients who are coughing up blood and can't breathe, that's pretty obvious. I've had a lot of patients I have a little more short of breath. I just don't feel as good. Then we get an x-ray and they have diffuse infiltrate. And then we get into the hospital and they get bronched and their lungs are a lot more blood than you would think based on how they're presenting. And they get kind of mild shortness of breath, mild cough. So anything can kind of prompt an x-ray to take a look. GI manifestations, it's not typically you're going to see it in the clinic because it's usually pretty severe if they have intestinal vasculitis where they have intestinal angina. So they eat something and they start hurting. So it usually makes them lose weight because their blood vessels are so thrombosed or are narrowed, that they can't supply the intestines with enough blood, and it leads to severe pain and cramping, and potential ischemia of the lumen of the intestine, which can lead to bloody stools. Ocular manifestations, red, painful blurred vision. Peripheral neuropathy, this is one that's really easy to catch in the clinic because it allows, it's something patients may not notice. And that's when patients start losing the sensation in their toes. And it can be subtle, so if they're having a hard time breathing, or a big rash that they're worried about, they may not notice they can't feel their toe. So just having the patient close their eyes and touch both toes, the big toes, and say, hey, look, do you feel it? Is it equal? Because what typically happens is you lose sensation at the tip of the toe, and then it kind of moves proximal. You lose sensation all the way up to the ankle, then halfway up the calf, and then all of a sudden, motor loss happens, and you get a foot drop. So just checking to see if they have normal sensation in their toes is quick. If one is a little bit diminished compared to the other side, then you just kind of have them dorsiflex the toe against your finger, and then see if there's a difference in how strong their toe can be. So just kind of watching for that is really quick and easy to do that, and patients may not notice it, and that's going to prompt much more aggressive management when the nerves are involved. And it almost always starts in the legs, almost never starts in the hands, but it can happen, but it's usually the legs where this starts. Then renal involvement, checking creatinine and checking urinalysis is really important. So creatinine can bump. So elevations in creatinine is not uncommon, and a whole lot of different things can do that. But the big trick to recognize if there's vascular process happening in the kidneys is a urinalysis. And if they have blood in the urine that's new, that's a really big red flag that they could have an active glomerulonephritis or active vascular process happening in the kidneys. We see that a lot in the hospital where a patient can get admitted. They think it's pneumonia, and they have a rash, and then they said, oh, it's probably some infectious rash, and then they give antibiotics, they don't get better, and they finally have diffuse alveolar hemorrhage. They finally get diagnosed, and we look back and say, oh, this patient's had blood in their urine for months. That's kind of the big kind of smoking gun. This patient has this process for a long time. And then a biopsy would be very helpful in making that diagnosis. So workup, reasons to admit, CBC, BMP, looking for the creatinine to be up. Do they have anemia, looking for evidence of diffuse alveolar hemorrhage? Urinalysis, looking for blood. Rheumatoid factor and C3, C4. Not necessarily looking for rheumatoid arthritis, because it's not usually a subtle diagnosis at that point, but looking for cryoglobulins. Cryoglobulins take weeks or a week to come back, but most patients with cryoglobulinemia vasculitis have rheumatoid factor positive, and their C3 and C4 are low in patients with cryoglobulinemia vasculitis. So that's kind of the thumbprint of cryoglobulinemia vasculitis. That's kind of just a quick and easy, this patient might have cryoglobulinemia vasculitis. ANCA testing, it's easy, it's not too expensive, and it will change management in these patients. And hepatitis panel, looking to make sure these patients don't have hepatitis B or hepatitis C, that would definitely change management, as you can imagine. Checking an x-ray, is important. Any evidence, any hint this could be endocarditis, checking blood cultures, it's cheap and it would absolutely change what we do. So now let's kind of focus briefly on treatment. So I have arrows pointing everywhere because we don't have a clear understanding of where to go with management of primarily limited cutaneous vasculitis. Though, let's say a patient, you worked them up, they don't have any evidence of systemic involvement. It may have it's not self-resolving, it's been persistent for weeks, and it's really bothering the patient. Okay, what are you gonna do? How are you gonna treat this patient? And the answer is, there's a whole lot of different options, and we're not so sure how they work or how well they work. And the reason that is because, we give prednisone, that works for everything. And then we have colchicine. The funny thing about that is colchicine so far is the only randomized controlled trial in leukocytoclastic vasculitis, and it was a failure. It was done in 1995. Where they used colchicine twice a day in patients with leukocytoclastic vasculitis versus placebo, only for 1 month. It was a small trial and it was a short trial. But interestingly, colchicine was no better than placebo at causing remission in leukocytoclastic vasculitis. What gave a hint that maybe it was working is because all the patients who were on colchicine at the time of the trial, when the trial ended and they stopped colchicine, most of them flared up. After stopping, they're like, oh, well, maybe there is something about colchicine that works. So from there, we use it, and I think it works in certain patients, but the problem is we can't really predict who it's going to work for. But if it's tolerated, because twice a day can often lead to pretty bad diarrhea, which could be pretty debilitating for the patient. Then we have dapsone, and we have that evidence based on grade anecdotal, grade A anecdotal evidence that this works in patients. So it's, I've seen it work unbelievably well in patients, but as soon as they stop it, the leukocytic class comes right back. So I think it does work. The problem is it doesn't work for everybody. And you have to check for G6PD beforehand. And then there's evidence of DMARD therapy with azathioprine, methotrexate, CSEP, CellCEP, mycophenolate, you name it. There's probably been looking at its use in leukocytoclastic vasculitis in patients who have failed multiple things. So the answer of what should you start this patient on depends on the patient and talking to them about the risks and benefits of these drugs. We don't have a clear understanding of which one is better or worse for these patients. Interestingly, I'm going to jump to this because I know I'm running out of time, but this trial I'm very excited about. It's ongoing. It's called the ARMIS trial, and it's a pretty uniquely structured trial in rheumatology. Unfortunately, I'm guessing COVID had something to do with why we don't have the results yet. So it was actually opened in 2020, and it's still ongoing. So it's a randomized multi-center study of isolated skin vasculitis, and the trial design is somewhat unique in the fact that it's going to enroll all these patients with limited skin involvement of vasculitis, and it's going to try a couple different things. It's going to try starting with azathioprine, it's going to try starting with dapsone, and it's going to try starting on colchicine, and then see how they do. And if they flare, then they're re-randomized to another drug. Okay? So it's a pretty new design in the rheumatology world anyway, to try and get a better idea of maybe what drug might work better than the other. I was at the American College of Rheumatology conference last year, and they were talking about the study design, and they pointed out that, like, oh, we have dapsone, we have colchicine, but we have no idea if any of them work. And I was like, oh, I didn't really realize the data was so bad for these drugs, and it really is. It's not great, and the one trial we have shows it doesn't work. So it's like, okay. So hopefully this will actually answer the question a little bit better than what we've had before. But I can't tell you, I imagine it's kind of any day now we're gonna have the results now, because it's been 4 years since it opened up. But otherwise, in patients, when you're working them up, the treatment absolutely depends on what caused it. Again, in the idiopathic cases, which is 50% of the cases, 50% of the time, but if you have that other half where you have a known cause, that can really change how you manage these patients. Underlying viral infection, often self-limiting. Hepatitis B or C, treat underlying infection. Endocarditis, obviously treat the infection, get them admitted to the hospital. They might need cardiovascular surgery. Drug-induced, stop the drug and wait. Vaccine-induced, hopefully time will fix it, right? And then we have the autoimmune diseases, which kind of open up a whole nother bag of worms of treatment, where rheumatology is typically managing this treatment, which is much more heavy immunosuppression, and most of these patients have systemic involvement. This is a quick diagram of cases of kind of evaluating a patient and when do you try. Look at the bottom right is steroids, colchicine, dapsone, or petoxyphylline. Just pick one, right? I don't know which one is going to work, but hopefully the ARAMIS trial will kind of give us some guidance in the future of how to best treat limited cutaneous disease. But hopefully the results will be back. Hopefully this year, we'll see. And hopefully we can prove these drugs actually do something besides those nice grade A anecdotal evidence. So another kind of excitement in the field of which could be cutaneous is IgA vasculitis. I want to end on that because there's some future hope that we have more therapeutics for IgA vasculitis. Most of this trial design is looking at IgA nephropathy, IgA nephritis, and whether or not that will be applicable to skin manifestations is a question. But the big excitement in IgA right now is complement inhibition. And that's going to look at, they recognize that lots of these patients in both the kidney and the skin have a lot of deposition of different components of the complement cascade, and potentially open the door for inhibiting different aspects of the complement system, which really open the door for getting patients off steroids and finally having a therapeutic that may or may not work for IgA disease. Again, most of the trials are looking at this kidney manifestations, which is very, very, very common. But whether or not these drugs will also be useful in IgA vasculitis of the skin is a big question mark, but it's exciting, a prospect, and there's like dozens of trials occurring as we speak. A few of them have already failed, so that's a bummer, but a couple of them are on to stage 3, so that's exciting, and hopefully we have a prospect. IgA can be really, really, really hard to treat, so hopefully that'll be opening the door in the near future. So conclusions. Cutaneous vasculitis, importantly, it's a downstream presentation of numerous physiologic processes: infection, drug-induced, autoimmune, malignancy, or idiopathic. We don't know, right? Welcome to my world in rheumatology. So treatments, steroids, dapsone, colchicine, DMARD, big question mark. Hopefully we know more after the Aramis trial. And then IgA has some hope with complement inhibition, but that's probably going to be years until we know that, and it's primarily going to be looking at the kidney, but hopefully that has some application to the skin. Time will tell. Thanks for listening. Pretty good on time, right? All right. Thanks.
Any questions for Dr. Brown? We do have a microphone here. Adam, you mentioned the Aramis trial. We were a site for that, Carol Langford and I. That study was very hard to enroll for based on their inclusion and exclusion criteria. And Rob Micheletti gave this lecture 2 years ago, and he did provide an update, but I'm not sure where they are either.
So it's just an enrollment problem right now?
Well, it was for us.
Okay.
It was really hard based on the inclusion-exclusion criteria. And, you know, think about the Cleveland Clinic and the Vasculitis Center, how many patients come in here, and we couldn't enroll a single patient.
Exactly. No.
So hopefully they do have their enrollment, and we'll have some results soon. You mentioned endocarditis. Do you work up endocarditis in every patient you see with vasculitis? Is there an age threshold or?
Yeah, good question. I think blood cultures are cheap, you know, and it's one of those things that could profoundly affect what you're doing. So I can tell you I've had a few patients who had like a clear, like they just got a vaccine and they got leukocytic vasculitis and they had all their workups, their kidneys are good, everything else is good, and I'm just doing colchicine, so I'm not necessarily immunosuppressing them. So I don't do blood cultures on that patient when they have a clear inciting factor, but I have a pretty low threshold to do blood cultures, and especially if they have any, the big clue to me is when they have a whole lot of autoimmune serologies, like they have lupus positivity and multiple lupus studies, plus they have ANCA, which they should be totally separate. When you have like a ANCA positivity plus lupus positivity, that's kind of the big red flag that they could have endocarditis. So when often these patients come to me, they're like, oh, something's autoimmune happening. Look at all these serologies. Like, oh, if all these serologies are positive, that means it's either a drug doing it or it's infection. And infection, the big one you don't want to miss is endocarditis. So that's by far we catch the most endocarditis. Or if it's drug, it's almost always hydralazine. So those are the two things that really prompt these serologies. But yeah, so if they have a clear inciting, you know, process that I think is causing it, and otherwise feeling great, and their labs look totally normal, I don't typically draw blood cultures. But otherwise, probably 80-85% of them I do blood cultures just to make myself feel better, especially if I'm going to induce immunosuppression, right?
Mm-hmm. You also mentioned, and in the literature this does come up, that this small percentage of patients who have vasculitis develop it as sort of a perineoplastic phenomenon. And I know you mentioned that you can't remember seeing a patient. Yeah. Is there a clinical presentation that would ever prompt you to order a malignancy screening workup? Sure.
Yeah, I think that older individual with precipitous weight loss is kind of the big kind of concern. And it's usually like I've kind of been wasting away, which could be back to, I keep harping on endocarditis. That's what endocarditis can look like too. So if they have this patient who's a older individual with weight loss over the course of months and months and months, it's not feeling good, wasting away, I ask them the basic like screening questions like colonoscopy, mammogram in women, and those questions. But then, yeah, you're right. Because even if they have vasculitis, it's not unreasonable to do imaging because you're looking for systemic involvement anyway. I don't order CT scans on all patients with leukocytic vasculitis, but if they're having like kind of like other B symptoms, like unusual fatigue, severe fatigue, this precipitous weight loss, then I have a pretty low threshold to do CT chest, abdomen, and pelvis.
And then in adults, I think, certainly in our department, the most common type of cutaneous vasculitis we see is IgA-mediated vasculitis. And we do have these patients who they have chronic vasculitis. And like we've seen patients do well on dapsone, maybe colchicine. I don't feel like we get very good results with colchicine, azathioprine. What do you do when those fail? And, CellCept, methotrexate. It's great that we have all these trials going on with complement inhibitors, ravulizumab, et cetera. But right now, If your traditional steroid-sparing immunosuppressive agents fail, where do you go? Is there a role for rituximab?
We used rituximab a handful of cases with pretty good results. Maybe not complete clearance of skin, but usually improvement. So in patients who failed one thing after another, I usually, before I would go to cyclophosphamide, I would do rituximab. For example, back in the day, we'd use cyclophosphamide in these patients, but I think rituximab has been kind of taking over rheumatology. So that's being used a whole lot more commonly in these patients. And it works or it doesn't, you know, and mostly it at least improves patients' skin. I think it's just kind of a big gun to use, but IgA can just be brutal on the skin. So I think that when it's like one of those cases when it's a few dots, like, oh, well, you know, probably not, but sometimes it can be ulcerative, painful, they can't walk because of them. That's kind of what we usually go to. You know, whether or not JAK-STAT inhibitors, all the other categories could work, it's a big question. JAK-STATs are nice because they work quickly, and you can stop them if they don't work, whereas rituximab, you give it to them and you're kind of like, that's it for 6 months, that's what you got. So it's kind of a big question mark. I hope we know more about the kind of faster acting drugs in IgA soon, so then maybe we don't have to rely on rituximab, although it's nice we have rituximab, well, we didn't have it in the past.
Great. Dr. Lim.
Sure. Yeah. So the question is, you know, and from a clinical standpoint in the community, what are things to watch for that really prompt you to admit the patient, or you know, get them seen at rheumatology? And I think that you can gain a lot of information with the CBC, BNP, and a urinalysis. If their creatinine is normal, that makes me feel a whole lot better. If their CBC is normal, meaning they don't have severe anemia, if they have severe anemia, that'd be concerning because that means that they could be bleeding somewhere, and particularly the lungs, and so that's a concern. And then the urinalysis is just typically it's blood. So we're looking for hematuria, microscopic hematuria in these patients. Different things can cause hematuria, but if you have vasculitis in the legs and you have hematuria, it's a big red flag that this patient could have impending renal involvement. Or if their creatinine is normal, it may not be normal for long. So that's a totally reasonable patient to get worked up quickly, because then we get rheumatology or nephrology will spin the urine and look for casts, which can kind of give a better indication that they have renal involvement, and a biopsy may be useful. And then the ANCA may come back a few days later, but that's what I would primarily look for is the kidney involvement. So a normal BNP, a normal urinalysis, a normal CBC makes me feel a whole lot better, and as long as patient's otherwise feeling well. But if they have some abnormalities in those things, I'd probably get them seen.
One more question.
So the question is, what are the causes of hypocomplementemic with patients with LCV, right? So is that right? Yeah. So it's sort of broad. I think that the big scary one is endocarditis, as I mentioned. Most patients with endocarditis develop immune complexes. Like 90% of patients with endocarditis develop immune complexes floating around, which can lead to leukocytoclastic vasculitis, and also drops your complement. Okay. So the other ones are urticarial vasculitis. That's hypocomplementemic urticarial vasculitis. I had some slides on, but I was gutted that I had to take them away because I was talking too long last night when I practiced this. But it was urticarial vasculitis it looks different, right? It looks like urticaria. The big difference is that it's urticaria that does not move, right? It's fixed urticaria lesions, and as they resolve, they leave kind of ecchymotic bruises, okay? So when they biopsy it, it shows urticaria plus leukocytoclastic vasculitis. That could be hypocomplementemic or normal complementemic. If it's hypocomplementemic, then you worry more about systemic involvement, it can cause like allergic systemic involvement, like angioedema and glomerulonephritis. So if it's hypocomplementemic, that makes you worried more about the kidney and the airway with angioedema. So urticarial vasculitis, endocarditis, and then from a more autoimmune standpoint, cryoglomerulonic vasculitis is the big one. Cryoglomerulonic vasculitis is primarily driven by, in the autoimmune world, Sjogren's, but in the hematology world, it's primarily driven by Waldenstrom's macroglobulinemia, but that doesn't usually present with LCV, it usually presents with Raynaud's. So it's usually an autoimmune standpoint, it's hepatitis C, hepatitis B, or Sjogren's syndrome or lupus. driving that. So checking an ENA panel, extractable nuclear antigens, will look for SSA positivity, which kind of gives you Sjogren's, or if it's like chromatin positive, RNP positive, it may be a patient with underlying lupus. But if the complements are low with rash, it may very well be cryoglobulins doing it. But again, that gets to the point of it doesn't give you a diagnosis quite yet. It kind of says what caused the cryoglobulins, and it's infection or Sjogren's or lupus primarily from an autoimmune standpoint. Type 1 is usually, type 1 cryos is where you get hematology oncology. That's it usually, but it doesn't usually present with LCV as much.
Thank you very much, Adam.
Thank you.
Our next speaker is Dr. Heidi Jacoby. Dr. Jacoby joined the faculty of UT Southwestern Medical School in 2002 after serving on faculty at the University of North Carolina. Dr. Jacoby's predominant clinical and research interest is morphia and localized scleroderma. She runs a comprehensive sclerosing skin disorders clinic and provides care for patients with morphia, systemic sclerosis, and other sclerosing skin conditions. And as Director of Phototherapy Services, she also specializes in the use of ultraviolet light to treat eczema, psoriasis, and other inflammatory conditions. Dr. Jacoby is also the Associate Director of the Education and Career Development Programs, the Center of Translational Medicine, and Clinical and Translational Science Award at UT Southwestern Medical School. And I got an email from Dr. Jacoby yesterday at 7:30 in the morning, unfortunately telling me that a storm blew through Dallas and a tree unfortunately fell on her house and did some damage. So she was unable to travel here to be with us in person, but she was gracious enough, despite everything that happened yesterday, to record her presentation yesterday, send it to us, and so she's going to talk to us this morning about an update in the treatment of fibrosing skin diseases.
Hi, everyone, and thank you so much for allowing me to present virtually. Unfortunately, we had some severe weather in Dallas, which has impacted my travel arrangements. And it's my pleasure to talk to you today about the treatment of sclerosing skin conditions and really focus in on the evaluation and treatment of morphia. So a little bit just about what I do and how I'm able to share with you the knowledge that I am sharing with you today. So I'm the principal investigator and founder of the Morphia in Adults and Children cohort. We have approximately 1,000 children and adults with morphia in the cohort who we follow longitudinally and also collect biological samples. And really all of the information and data I'm sharing with you today was the result of the years of work with these patients and their donation of their time, money, and even themselves to allow us to do our studies. I am delighted to collaborate with others, so please reach out if you have interest. And this is my research team, and this was taken about a year ago when we reached 900 patients, and we anticipate in June we'll reach 1,000 patients, so this will be the largest morphia cohort in the world. So excited to have a 1,000 patient party. So what my experience has helped me do is really start thinking about how do you approach a patient with a sclerosing skin disorder? And so these are the key observations that I'd like to leave you with today. First of all sclerosing skin conditions are characterized by a sequential evolution over time of inflammation, sclerosis, and pigmentary alteration and atrophy. And so what that means is you can assess an individual patient and really look at what disease state they're in. This is also really important because if a patient presents to you with lesions that are exclusively atrophic or dyspigmented without any sign of clinical inflammation or sclerosis, it is very, very unlikely that those lesions are of new onset or active. And so this really helps you in evaluating patients and then making a rational decision in terms of what treatment is needed, if any, medically. The second is that most of the existing therapies that we have, whether they be topical phototherapy or systemic, target inflammation and not really sclerosis. So the treatment for sclerosis is poorly developed. And so the outcome you're looking for as an early sign of therapeutic success is not, in fact, improvement of sclerosis, but actually improvement of inflammation. The third is that the first aspect of assessing any patient in terms of whether they need treatment for active morphea or not is the disease state, active or inactive or a mix thereof. The second is the depth of involvement, so dermal, subcutaneous, or even deeper into the soft tissue. And the final is extracutaneous manifestations, which importantly can be determined and risk stratified by the clinical presentation of the patient. Finally, is that when you take all of this together, the treatment should really target the correct disease state based on your assessment, the depth of involvement, and the presence or absence of extracutaneous manifestations. So for that reason, let's get started in helping you to understand all these pieces of evaluation so you can make the best treatment decisions possible. So the key to understanding people with sclerosing skin conditions is not so much based on any laboratory tests, nor is it based entirely on imaging, although it can be helpful. We'll get to that later, but physical examination is absolutely key. So the first thing is that you need to examine the whole patient and the whole body surface area in a gown, have them stand up, have them make faces if they have facial lesions. You also really have to palpate the skin. As dermatologists, we aren't used to doing that, but visual exam alone is not helpful in sclerosing skin conditions. Make sure the person's muscles are relaxed. Take yourself as an example and tense your forearm and just feel the firmness of your skin. So now relax completely, just let it flop by your side and feel the difference. So the other thing is that you have to pinch or move the skin, not just palpate it, especially over bony prominences. So for example, use your own finger in comparison to another person's and the ability to pinch or move the skin. On the forehead, if you have atrophic skin and you wrinkle your forehead, you'll have more wrinkles. If it's sclerotic, it will actually be thicker. So be sure to palpate and use skin motion and pinch the skin, not just pressing on skin, which over bony prominences can lead to false conclusions of sclerosis. And lighting and side lighting is absolutely key to appreciating texture and atrophy. So let's start with a differential diagnosis. So what we're going to focus on today are the following, highlighted with the blue oval. And these are really disorders that are pathologically characterized by excessive collagen deposition. You don't see proliferation of fibroblasts very much in these conditions. And early on in the active disease state, you can see a variable degree of inflammation, both in a perivascular distribution and sometimes in that junction between the dermis and the subcutis and even down into the septi. So that's really what we're working on today. Within this group of disorders highlighted here, the pathology results are not always clearly different from one to the other. And it's for that reason that understanding the clinical manifestations of these conditions is absolutely essential to allow you to adequately differentiate them. So let's go through an algorithm that can help you differentiate between these different items on the differential diagnosis. If you have pathology that shows excessive collagen or extracellular matrix deposition, some degree of inflammation, but not a lot of fibroblast proliferation. So the first you'd want to inquire about is environmental exposure, chemotherapy, occupations such as vibration, porphyria, risk factors for porphyria cutanea tarda, or history of radiation exposure, either therapeutically or iatrogenic, or even as part of other procedures or occupational hazard. So in this case, you are likely dealing with a sclerodermoid mimic of some of these other conditions. Now, the constellation of Raynaud's phenomenon, acrosclerosis, sclerodactyly, dilated nail fold capillary loops, and a consistent serology, i.e. presence of centromere topoisomerase or RNA polymerase antibodies, should strongly suggest systemic sclerosis. And an older condition, which we don't see as much anymore, but to be aware of, is a patient with renal insufficiency, especially end-stage renal disease, with a history of MRI with gadolinium exposure, is really going to be suggestive of nephrogenic systemic fibrosis. Again, not common with changes in guidelines regarding gadolinium exposure. And so another entity to be aware of is those who have underlying diabetes mellitus or monoclonal gammopathy with a distinctive distribution, including in the case of scleromyxedema, the leonine facies, and other changes in scleroedema of the upper back and proximal arms. Is going to be, again, a clue to a different condition. And here you can also sometimes see mucus in the case of scleromyxedema. And then also not uncommon that I see is prominent venous varicosities and other risk factors for venous stasis, and lipodermatosclerosis, especially in the acute phase, is a consideration. So if you have the absence of all of these and the clinical features we're going to go through next, you very likely have a condition of morphia or eosinophilic fasciitis. Notably, about 30 to 40% of people with morphia have positive ANA up to very, very high titers. So the presence of this in and of itself, with the absence of other hallmark antibodies of scleroderma or lupus, is consistent with a diagnosis of morphia alone. So we talked about the cutaneous distribution and demographic features of morphia as being distinctive. Let's go through some of those that will really help you solidify your diagnosis. So the main subtypes of morphia that we reported on that really accurately classify greater than 90% of individuals are as follows. So circumscribed, these are the classic oval, round, indurated plaques. Generalized, more than 4 plaques greater than 3 centimeters on more than 2 body sites, oftentimes confluent. The worst subtype of morphia in terms of actually having mortality associated with it in severe clinical manifestations is pansclerotic. These are confluent, full thickness plaques that really involve not just the dermis, but the subcutaneous tissues as well, and wrap really circumferentially around the trunk and spread outwards to the extremities, face, and scalp. They have a distinctive cutoff at the wrist and ankles, or the MCP and MTP joints, so it spares the fingers. Linear is really, really predominant in children or young adults, and these include linear plaques of the face called incudescence, scalp, extremity, or trunk. Mixed could be a mixture of the above subtypes. This is actually very rare in my experience, and any of these subtypes can have deep, i.e. soft tissue involvement. So soft tissue involvement in and of itself and or findings like fasciitis are not exclusive to one subtype. They can really occur across the board. So here are just some illustrative photos. These round, ovoid, circumscribed, scattered plaques that are asymmetrical, usually adult predominant. Generalized, here you can see these are individual plaques that have become coalescent. They are symmetrical, affecting the trunk and extremities of this individual who's very hyperpigmented because he was treated with UVA1 phototherapy. But you can see from this that initially circumscribed lesions can be a transitional state, which if followed over time can become generalized. So it's important to follow patients with circumscribed lesions to make sure they're not evolving to be generalized. Here's an example of pansclerotic morphea. You can see this deeply bound down, full thickness sclerosis really extending into the soft tissue, involving the trunk, the extremities, and again, that abrupt cutoff at the MCP, you'll also see at the MTP joints, as well as the sparing of the areola in what they also has been described as a tank top distribution, are all characteristic of this condition. These lesions evolve very rapidly over months, and this is a condition where you really want to treat it aggressively. Linear is very predominant in children. Into young adulthood, you can see here this can involve the extremities, like the legs on the right thigh of this individual, as well as the trunk, where it's commonly thought of to be circumscribed, but the unilateral nature and the abrupt demarcation at the midline are all hints that you have a linear lesion. It is not uncommon to see multiple linear lesions, although typically those affecting the face tend to remain above the neck, and those below the neck tend to remain below the neck. And you can see here a patient with multiple linear lesions, including her abdomen and her arms. And then here the typical linear lesions of the face, also known as incudasab, or the cut of the sword. One thing that's important to remember in patients who have linear lesions affecting the face, remember I talked about that you can have soft tissue involvement in any of these situations, and that is true for linear. And so what you see is, in that case, is you can see what is essentially a dermal plaque overlying an area of subcutaneous atrophy. So whenever you have a linear lesion, it's important to compare the affected and unaffected side, and you can see here positioning really reveals hemifacial atrophy for this young boy who has a characteristic linear incudasab lesion of his forehead. So it's always worthwhile to take a step back and look. A new observation for us with linear morphea is that patients can develop linear morphea lesions into adulthood, typically into their 20s. And in fact, about 30% of patients with linear lesions do have these lesions with onset into adulthood. The second point is that patients continue to have active morphea into adulthood. It remains linear. So these patients require continued follow-up beyond the childhood years. One of the most important things when considering how to treat a patient with morphea is whether the disease state is in its state of activity or damage. So let's talk about what that means in terms of clinical observation. Lab tests are not helpful here. It's really based on your clinical exam skills as well as history taking with the patient. So activity is denoted by signs of inflammation. So erythema at the periphery of the lesion combined with induration, reflecting an edematous state, new or extending lesions that are active. Remember, a lesion that is solely hyperpigmented and atrophic is not new. So new active lesions are key here. Oftentimes these will have a sclerotic center and can sometimes be itchy. Damage is all related to pigmentary alteration, atrophy of the dermis or subcutaneous tissue, and sclerosis is a transitional state. So you can have central sclerosis, but if you have hyperpigmentation surrounding the sclerosis, that means the lesion is tending towards being inactive. So this is a great example of active lesions. You can see that they are erythematous to almost violaceous. The pale center is actually, if you were to biopsy it, sclerosis. And these are circumscribed lesions that are in a linear distribution on the leg, which makes sense because this is a child. The extra credit point is actually the knee effusion. So this patient also has an inflammatory arthropathy, which is the most common extracutaneous manifestation in people with morphea and can also include fasciitis and myositis. Damage is illustrated again by this child who has bilateral lesions affecting the dorsum of his hands, and subacute atrophy you can see by comparing the two hands and the loss of the fatty tissue in the fingers and at the dorsum of the hand, making the tendons more prominent. We see hyperpigmentation, and then here we can see this shiny part is sclerosis or skin thickening at the center. In addition to that, the shininess of the lesions here, in addition to the subacute atrophy, indicate dermal atrophy. So these are all features of damage, and this patient would not be responsive to immunosuppressive therapy. So now that we understand what morphea subtypes are, we've talked a little bit about the depth of involvement, and then we've also gone through activity and damage. This sets us up to understand what defines therapeutic success. So these are spaghetti plots, and if you take a moment to look at these, what they indicate is these are the lossy scores. So these are the features of activity that I denoted: inflammation, new lesions, peripheral induration at the baseline visit of individuals. And you can see the top are people with linear morphea, the bottom are generalized morphea. These patients received standard of care therapy. So for me, that's going to be, excuse me, methotrexate, rarely along with systemic steroids, sometimes Cellcept, and in cases of dermal generalized lesions or dermal linear lesions, UVA1 phototherapy. And what these figures show is that if you go out to 1 year with these visits in between, is that the vast majority of people really start, and these are the mean scores, you can see really at around 6 months, the vast majority of people on standard of care therapy reach an activity score of 0. So there's a couple of important takeaway points here. One is that activity responds to appropriate medical therapy in a lot of patients, as you can see here by these individual score trajectories. There are a few aberrations and outliers, but you can be confident that most patients, if appropriately dosed and adherent to treatment, will reach an activity score of 0 at 6 to 12 months, which means the signs of inflammation have resolved. And that is a successful therapeutic outcome. And one of the biggest kind of challenges I find is the temptation to escalate treatment over this interval. And it really is not necessary because the treatments do really shut down activity very well, even the standard of care ones. Now, the other thing to remember is once you've treated someone successfully and you discontinue the therapy, what is their risk for disease recurrence? And this shows basically that people who are treated with methotrexate tend to have lesser recurrence over time than those treated with UVA1 phototherapy. This also somewhat goes along with the disease subtype, linear being generally less recurrent than generalized, although this is somewhat confounded by the therapeutic indication, since my generalized patients tend to get UVA1 phototherapy more than linear patients. But what we can tell from this is that somewhere around 30% of patients with linear morphea will have recurrence of disease activity if followed out from 2 to 5 years after their last treatment. In cases with those with generalized or treated with UVA1, that figure is probably closer to about 40 to 60%. So these patients do have recurrent activity and warrant long-term follow-up. They do respond to treatment if you reinitiate the same treatment because it's not a therapeutic failure, it's simply recurrence. The other important point is what happens to damage as you treat activity. And what you see is that once you have abrogation of activity and inflammation, the sclerosis will continue to resolve after the discontinuation of treatment and can be replaced by atrophy. So successful treatment oftentimes results in increased features of damage, such as atrophy and hyperpigmentation. And this is a great example here, actually, that activity and also sclerosis resolve at different time intervals. So this patient has pansclerotic morphea, and we treated her with prednisone, methotrexate, as well as UVA1 phototherapy. And you can actually see here from these photos that her erythema, and this is about 4 months in to 6 months in, her erythema is resolving. She's starting to get hyperpigmentation and a lot of softening on the trunk, which is typical. The trunk tends to respond the best and the earliest. In contrast, the further you go out on the extremities, particularly the lower extremities, the slower the lesions respond and the longer it takes. So I never judge therapeutic efficacy early on by the extremities, especially the distal extremities. 3 to 4 months in, I would judge therapeutic efficacy in the central truncal areas. And I'm, obviously in linear patients, the lesions themselves. But if they are far out on the periphery, this really, they lag behind by several months. So I would not have called that patient a therapeutic failure. I would have said, you're doing great at 3 to 4 months. Let's start tapering you off the steroids and continue the methotrexate and keep you on the UVA1 for a total of 30 to 40 treatments. So the other piece of evaluating patients and deciding on their therapy goes with extracutaneous manifestations, which can be risk stratified based on subtype and cutaneous location. So I mentioned before, and it's important to reiterate, that musculoskeletal or soft tissue disease is the most common extracutaneous manifestation associated with morphea and often can present as an inflammatory arthropathy and linear lesions, particularly of the extremities, but can also be seen rarely in the TMJ. And fasciitis and myositis, especially in deep dermal or subcutaneous lesions in linear and generalized morphea. And you can see here in this patient, she has a very deep linear lesion affecting her right thigh. In fact, it's more palpable than visible. Her MRI shows soft tissue involvement of the subcutaneous tissue, fascia, and muscle. And she also has an infusion of the right knee and actually was diagnosed with juvenile idiopathic arthritis. Also fasciitis and myositis. So again, similarly, you see a patient with a poorly circumscribed lesion, which denotes deep involvement, deeply sclerotic, who is complaining of a lot of pain and stiffness when she tries to be physically active or do yoga with this affected leg. And you can see here that MRI shows enhancement of the fascia and inflammation in the muscle underlying this lesion, which is not uncommon, especially those with these deep lesions of the extremities. Neurological and ocular involvement, again, can be risk stratified based on the subtype and location. So these manifestations are very rare in morphea overall, probably affecting less than 5% of individuals. And the brain parenchyma is less well defined, but also probably uncommon. But those with linear lesions of the head or craniofacial morphea, which are linear lesions of the head, face, and neck, are at particular risk and should be assessed. So the ocular manifestations can range from episcleritis, uveitis, and even optic neuritis, as well as optic artery inflammation, as well as involvement of the soft tissue around the eye. And this should be really sought for, and patients referred to ophthalmology if they have a linear lesion of the head. Also, neurological symptoms or signs, headaches, other changes warrant further investigation. And certainly neurological deficits that are localizing or severe headaches warrant emergent evaluation. You can see this child who has a fairly subtle inactive linear lesion of the forehead actually was found to have paraventricular white matter changes in the brain, which are consistent with those that we see in a number of patients. This likely reflects microvascular disease in the brain and involvement of pediatric neurology or neurologists with expertise in neuroimmunology and vasculitis is really important to help manage these patients, especially in the presence of severe symptoms. Mucocutaneous involvement is again rare in morphia overall, but if you risk stratify by subtype, so linear lesions overlying the maxilla or mandible or pansclerotic lesions, greater than 20% of those individuals will have oral changes. A postmenopausal woman with generalized dermal plaques that are superficial, especially with overlying lichen sclerosis changes, more than 20% will have genital involvement. And you can see here illustrating that this patient has a linear lesion affecting her left face and mandible and neck, largely inactive at this point. And if you examine her gingiva, she actually has loss of gingiva underlying this lesion. And actually this has produced loosening of the teeth and the need for gingival grafting and replacement for therapy. Similarly, this patient has widespread, very superficial dermal plaques of morphia, very common in postmenopausal patients who have this phenotype with overlying lichen sclerosis change, tends to occur in sites of friction. And when you examine her vulva, you see she has quite advanced changes consistent with lichen sclerosis. So in women with these generalized superficial plaques, always examine the genitalia. So we've talked a lot about morphia evaluation. Let's move to therapy. As mentioned before, laboratory examination is of limited utility in morphia. There are no hallmark or diagnostic autoantibodies. ANA can be present in anywhere from 30 to 60% of affected individuals, even at very high titers. We found predominantly in the speckled pattern. You might see elevations of ESR-CRP, CK aldolase, and hypergammaglobulinemia, or even a positive rheumatoid factor. This goes along particularly with people who have widespread, especially deep lesions, but really are absent in a large majority of people with morphia. So evaluation, which can be aided by laboratory results, and laboratory results can be used to exclude other diagnoses, really is guided by the disease state, the age of onset, which goes along very closely with the subtype of morphia, the anatomic distribution of lesions, which helps you to, along with the suspected depth of lesions, which helps you to really risk stratify for extracutaneous disease, which should obviously also be accounted for in your management plan. To care for patients with morphia, I strongly recommend a multidisciplinary referral network of individuals who are familiar with this condition, or at least sclerosing skin conditions, and generally for those with more severe morphia, referral to a center that has familiarity with the condition. Treatment is really going to be based on the following really interesting insights that we've had into the immunopathogenesis of morphia. So we have found gamma interferon mediated chemokines in the CXCL 9, 10, 11 family are strongly associated with an active disease state in morphia, and also the extent and severity of these lesions. As a result, we've done a number of different studies and found that immune cells in the skin, as well as fibroblasts, are the producers of these chemokines based on single-cell RNA-seq data, and that what we actually are detecting circulating on the protein level in the sera is likely spilling over from the skin due to the large amount of these immune cells who are producing these chemokines in the skin. We collaborated with Gillian Richmond at the University of Massachusetts using a bleomycin model to see whether knockdown of these chemokines actually then decrease the production of sclerosis in the animal models. And we actually found that knockdown of CXCL9, as well as the receptor CXCR3 for CXCL9, really abrogated the sclerotic response in the animals. So this suggests not only is this an observational finding of the biomarker being associated with active morphia, but it likely plays an active role in pathogenesis. Combined with the recent studies with STAT4 in familial cases with pansclerotic morphia reported in the New England Journal of Medicine, this provides a strong rationale that these chemokines, the gamma interferon access and JAK-STAT signaling in these immune cells, play an important role in pathogenesis of morphia. And so this is also a good way to make rational decisions about treatment. As mentioned, a good response is really helpful and important to understand, and this is shown in this photo. This patient has a plaque of her leg that includes central sclerosis with surrounding erythema in a linear distribution. She was given UVA1 phototherapy, and after 30 treatments at medium to high dose, you can see that the erythema has turned to hyperpigmentation and the sclerosis has started resolving, but it is still present. And so the lesion has not cleared, and in some ways might be more obvious than what it was before. But this is an excellent therapeutic response, and our observation is that the sclerosis will continue to improve even after discontinuation of UVA1 phototherapy. Another important point is that early lesions improve the best and the most with the least residual change. This patient who had very early inflammatory lesions was treated with prednisone and methotrexate, and you can see within 2 months the lesions have nearly resolved without sequelae. And this is really expected if you can catch the lesions extremely early. So let's tie this all together. You have established a patient has morphia, and you've done your clinical assessment determining the disease state, whether it's active or inactive. You have assessed the depth of involvement, because the depth of involvement is going to guide you whether an outside-in or a more systemic treatment is indicated, knowing that superficial dermal lesions might respond to outside-in treatments. But if you have deeper dermal, subcutaneous, or soft tissue involvement, and obviously extracutaneous manifestations that are active, systemic immunosuppressive therapy is warranted. And you've also risk stratified based on extracutaneous manifestations and gotten the relevant consultants on board to help you manage those and make therapeutic decisions based on those. So if you have active disease and you have circumscribed lesions of just a few plaques, you can try topical directed therapies. You can follow those carefully with photographs and see if they are effective in about a 4 to 6 month interval. You also want to follow up in case these lesions become generalized or linear. If in about 4 months or so these are ineffective, or the patient is developing new lesions and you're just chasing them with the topical therapy, consider either a total body UV treatment if the lesions are superficial and dermal, or moving to systemic immunosuppressives. If the lesions are deep dermal, subcutaneous, or have extracutaneous manifestations, or which is linked to functional changes, you want to go with a systemic treatment. Methotrexate, about 15 to 25 milligrams weekly in adults, and then dosed similarly in children, and systemic corticosteroids at about 1 milligram per kilogram with a maximum of 60 milligrams of prednisone daily, tapered over 3 to 4 months, is going to be your first line. I only use systemic steroids in rapidly progressive, very inflammatory lesions, or in cases where I'm really concerned about extracutaneous or functional problems in patients. You're going to follow those individuals, and at about 3 to 4 months, you're going to start assessing whether the inflammation is starting to resolve, and the new lesions are becoming less and less frequent, and the lesions are no longer spreading, using photography, and consider increasing the dose. I typically taper off prednisone or my systemic corticosteroids over about 3 to 4 months. My patients are rarely on systemic steroids for more than 6 months. If those are not effective, I consider changing to mycophenolate mofetil, abatacept, or rituximab, depending on the overall state of the patient. Patients with inactive disease warrant treatment and management just as much as those with active disease, because they have significant psychological impact and impairment of quality of life resulting from damage. So physical occupational therapy and physical medicine and rehabilitation, pain management, psychological support, as well as working with a reliable individual on fat transfer for large volume loss of tissue, even potentially bone grafts and others if you really have large volume loss, as well as loss of underlying bony tissue, Botox, lasers, and other treatments to maximize cosmesis function and support individuals psychologically, as well as long-term follow-up, because remember, they do have recurrence of disease state. Finally, I'd like to leave you with the value of empathy for your patients. We do a lot of focus groups in developing patient-reported outcomes, and I've listened to the transcripts of these and found myself in tears for what these people have experienced and lived through dealing with this rare, poorly understood condition. And choose your words carefully. These patients oftentimes really anchor on specific words and will remember them 10 or 15 years later. I'm very thankful to all my collaborators. It truly takes a village to do this work. And the funding that I've received, and my lab team, and most of all, our patients here. So thank you so much, and I appreciate your attention.
One of the unfortunate consequences of Dr. Jacoby not being able to be here in person or present live virtually is that we cannot ask her questions. I know that myself and our residents over the past few months and seeing morphea patients have come up with a lot of questions that we wanted to ask Dr. Jacoby. So if you have questions during the break, you can write them down, give them to me, and I'd be happy to email them to Dr. Jacoby and get back to you. It's a pleasure to present our next speaker, Dr. J. Michelle Kallenberg. Dr. Kallenberg completed her MD, PhD, and her internal medicine training at Case Western Reserve University here in Cleveland. And then she completed her fellowship in rheumatology at the University of Michigan. Her clinical work is centered on the care of complicated lupus patients, including those with refractory skin disease. Her independent research laboratory is funded by multiple NIH, including R01 and Foundation Awards, and combines translational approaches using patient samples and mirroring models to uncover the mechanisms that drive lupus and other autoimmune diseases. In particular, she is focused on unraveling the pathogenic mechanisms of cutaneous lupus, the factors that drive photosensitivity, and how skin inflammation can influence systemic lupus activity. She is extremely well published. She has first author, senior author publications in high-impact journals like Science Translational Medicine, JCI in Nature Immunology. And one of her seminal discoveries from her lab includes the role of interferon kappa and of dysfunction of normal keratinocytes in lupus skin disease. She has received multiple awards over her relatively short career, including in 2022 being named the American College of Rheumatology Henry Kunkel Young Investigator Awardee, which is the top award for early physician scientists in rheumatology. And we are very happy to have her here. And she's going to talk to us about an update in treatment of cutaneous lupus erythematosus. Dr. Kallenberg.
Good morning, everyone. It's a pleasure to be back in Cleveland. The city looks great. I came through, I was like, it's been a while since I've been back. It looks really good. I thought I was asked to talk about updates in the treatment of cutaneous lupus. These are my disclosures, and I did put some references in my slides if you want to read more. So I think one of the interesting things about cutaneous lupus, and I think you experience this as dermatologists, and I see it as a rheumatologist, is that cutaneous lupus exists both with and without systemic lupus. And because you can have patients who have CLE only and patients who have CLE with SLE, you can have challenges when you're managing these patients depending on sort of which category they fall into. And with CLE only, I think our biggest hurdle is that we really have no approved drugs. And so getting medications covered for patients can be really challenging. And there's also been a lot of work, and you know this well, in terms of trying to define clinical outcome measures that will be accepted by the FDA to allow our drugs to be approved for patients who only have cutaneous lupus. Now, if you have a refractory CLE patient who has systemic lupus, then the challenge becomes often it's the organ-threatening manifestations of systemic lupus that define our treatment decisions. And sometimes the skin gets put on the back burner because we're worried about saving kidney first. And many patients who have cutaneous lupus with systemic disease will get better on therapies. So patients who get treated with CellCept or cyclophosphamide for their lupus nephritis, or they get methotrexate or CellCept for pleurisy or arthritis, or they get belimumab for arthritis, hematologic manifestations, lupus nephritis, or antibody-mediated features like low platelet counts. Sometimes patients, their skin will get better then too. And pretty much every lupus patient will get put on antimalarials, but we all have patients who still have active skin disease despite being treated with many of these drugs. And those with refractory disease often are forced to choose. So now we have anifrolumab, which I'll talk about, that is good for skin, but if they have active nephritis, they have to go on drugs for the nephritis, and getting 2 biologics covered is pretty much impossible. So I probably don't need to tell this audience about the cutaneous lupus subtypes, but I'm going to focus mostly on the common subtypes. There's lots of rare subtypes, which we don't have as much evidence base for treatment. So acute cutaneous lupus is the one we typically see in patients with systemic disease. It's the malar rash. It can also be a more widespread systemic feature. You have subacute cutaneous lupus patients, and you have chronic discoid where you get a lot of scarring alopecia as part of this disease. And really, when we think about refractory patients or patients who have more difficulty clearing their lesions, it's really the subacute cutaneous and chronic discoid patients that really have the most refractory lesions. Typically, the malar rash of acute cutaneous lupus, or even a widespread rash, will improve with systemic therapy. And so, you know, part of where my brain goes when I think about how to treat these patients is we really have to understand the underpinnings of cutaneous lupus to properly treat it and to rationally choose drugs for our patients. So I'm kind of doing my talks in reverse because I'm going to talk about the pathogenesis of cutaneous lupus at 2 o'clock today. So I'll try not to dig too deep into mechanism during this talk, but I think a lot of the reasons why you'll see what I recommend will be more clear once we get to the other talk later this afternoon. So what is the current standard of care for cutaneous lupus? So the first thing I want to highlight is that it's not just about drugs. So first, we really need to emphasize the importance of sunscreen in our patients, and this includes light-skinned patients and dark-skinned patients. I do a lot of work studying photobiology in lupus patients, and I can tell you having darker skin doesn't mean that your skin is protected from the sun when it comes to cutaneous lupus lesions. So when you look at keratinocyte dysfunction in Black patients versus white patients, they all have the same keratinocyte dysfunction, mitochondrial dysfunction, high production of interferons. And so you're not protected. And we have some mechanistic reasons why this is. But everybody needs to wear sunscreen, at least SPF 50 or higher. I'm sure this audience all drinks that Kool-Aid anyway. But it's recommended not to use spray sunscreens. You want to make sure they're using lotion to get better coverage. And really, the FDA no longer recommends chemical-based sunscreens as safe and effective. So it's really important to emphasize that they get a barrier sunscreen that contains titanium and zinc. And it's really important in darker skin patients to help them find options that can help with their skin pigmentation so they don't look white when they put the zinc and titanium on. It can leave like a really kind of chalky look. So there's some really nice tinted products out there. And there's lots of blogs that are helpful for patients to surf to find products that are within their range, and some of the products can actually be mixed with their foundation to actually help match their skin color quite nicely. So that, I think, is an important thing that we need to talk about every single visit with our patients. Smoking cessation is also really important. There's data that the efficacy of hydroxychloroquine is dropped by 50% if a patient smokes and they have cutaneous lupus. So they're basically tying one hand behind their back if they continue to smoke, despite all the medications we're giving. And the data suggests that the efficacy of something like belimumab goes down 6-fold if the patient continues to smoke while they're undergoing treatment for their skin. The other thing is important to do a really good medication evaluation and make sure they're not taking a drug that's actually causing the cutaneous lupus. So thinking about hydrochlorothiazide, antidepressants have been linked to cutaneous lupus, statins, PPIs, antifungals. So go through their drug list and really make sure that something isn't causing their skin to continue to be active. And then I always like to talk about diet with patients. The microbiome and leaky gut, there's a lot of data in systemic lupus, not so much in cutaneous only, but leaky gut is real in lupus patients. We see increased levels of LPS in patients when they have systemic disease flares. And so eating a healthy diet is probably really important. And not all of our patients have the resources to be able to just go out and buy organic whole foods groceries, right? So we have to help them strategize on how to eat healthy within the resources that they have. Exercise is also important. Just, healthy lifestyle goes a long way in keeping our immune system in a happy place. Sleep is also important. If you look at systemic lupus risk factors, the one thing that was identified in patients who are ANA positive who go on to develop systemic lupus, if you looked at all the risk factors that were listed, getting less than 7 hours of sleep a night was the one thing that pushed people into systemic disease. And so really talking about the importance of sleep and taking care of their bodies is also very important in these patients. And then stress reduction. We are learning more every day about how our nervous system directly communicates with the immune system. And so teaching patients ways to manage their stress, encouraging meditation, exercise is also a good way to help manage stress. So really, helping patients think through their, what things could be triggering their immune system to be going awry is important. And then the other thing is if you have a patient with CLE only, it's really important to keep an eye out for systemic disease, especially if they're not following with a rheumatologist. I don't know how many of you have tried to refer a patient to a rheumatologist, but they're in short supply. I think our access right now in Michigan is about 5 months for a new patient visit. So it's really important that if these are patients that you're seeing, that you kind of help keep an eye on things. So if a patient is ANA negative and they have cutaneous lupus, the risk to progression of systemic lupus is low. Also, if you're male or if you have localized DLE, these things tend to not be high risk for progressing to systemic lupus. So you probably don't need to, be pushing for labs all the time in these patients. But if they are ANA positive or they have widespread discoid, so it's not just on their face or scalp, but kind of covering more areas, or they have SCLE, these patients are more likely to progress, or if they're female. And so I would recommend that as a dermatologist, you at least get a yearly CBC, a urinalysis, a urine protein to creatinine ratio to see if they're having any proteinuria, just looking at their chem comp to look at their liver and renal function, get a set of C3 and C4 complements to make sure they're not low, and a double-stranded DNA. So I think keeping an eye on that in a patient who has a higher risk of progression is a good idea. And a one-time ENA 10 panel to look for associated autoantibodies if they're Rho positive, or if they have other things that are more associated with systemic disease like Smith or chromatin antibodies. Don't repeat the ENA 10 every time you see them. It's not recommended, nor is it recommended to keep rechecking the ANA in patients, but at least a one-time so you know their antibody status is important. So when we think about how to treat cutaneous lupus, I like this algorithm that Vicki Worth published a few years ago. She's really one of the gurus of cutaneous lupus in the world. And, you know, it starts with topical treatments. I don't know how to go back. So topical treatments are really the place to start. Glucocorticoids, in my experience, they kind of lighten things up, but they never really get rid of the rash. And one of the things that I have found useful is to switch to topical tacrolimus, especially for the face. If patients have persistent lesions that you want to keep doing some sort of topical treatment on because it doesn't thin the skin or have that risk. She doesn't put intralesional steroid injections on here. I know that some people do them. I think for really refractory scalp lesions, they still can be quite helpful. And then really, you know, once patients have kind of gone through topical treatment, if they have more than 1 or 2 lesions, it's really adding hydroxychloroquine is the next step. And it's really our workhorse. And I think one of the things that, you know, we've all gotten really scared of in the past 10 years because of the study that was done looking at, you know, dropping the dose of hydroxychloroquine to 5 mg per kilo, without a lot of really good evidence that didn't hurt our patients in terms of efficacy of hydroxychloroquine, is that we shouldn't be afraid to kind of push the dose to get people into remission. So there was a really nice study that took patients with cutaneous lupus and they kept increasing the dose of hydroxychloroquine to get their blood levels over 750 mg per deciliter. And you can see here that what they saw was that if you pushed the level to over 750, you could induce most patients to get to a pretty low CLASI score over time. And half of these patients had CLE only, and half the patients had CLE with SLE. And so really making sure that patients are getting enough hydroxychloroquine, at least to get into remission. And then I think you can back off on kind of a maintenance level and keep following the drug levels. Michelle Petrie has published really nice data suggesting that if we keep the level kind of under 700, the risk of retinal toxicity is pretty low. And so I tend to follow levels now and not pay so much attention to the weight-based dosing. It's also really helpful to check levels because it really tells you if patients are taking their drug. So if I get a patient whose level comes back at 150, I know they're really not taking their, they probably took it that morning because they knew they were seeing me, but you know, they're really not taking their hydroxychloroquine regularly. So sometimes treatment failure is really just failure to get the drug to an adequate level. The other thing that we used to do a lot more often when quinacrine was more readily available was adding quinacrine to hydroxychloroquine. There is now at least one mail order compounding pharmacy called Chemistry RX. It's based out of Philadelphia that will mail patients quinacrine. The trick is getting it paid for. So it's about $300 a month if you're going to pay cash. Chemistry RX will do appeals for you. They have a 15-page letter that they will send to insurance companies to try to get coverage. I've had one patient get their insurance to cover quinacrine, and that's been great because she really does well on quinacrine. So you can try to see whether you can get quinacrine to add. It's really quite useful when you add it to hydroxychloroquine. When I started practicing as an attending, you know, pretty much every one of my patients got this added on as sort of their next step. And then we had a supplier issue and it went away for about 3 years. So now it's back. But these studies here just show what happens when you add 100 milligrams of quinacrine to patients who were already on hydroxychloroquine. You can see you can get improvement in the CLASI scores. And Vicki Worth had a similar study where she showed that 67% of hydroxychloroquine non-responders had benefit with the addition of quinacrine. And she's actually done some nice mechanistic work showing that Plaquenil versus quinacrine have different effects on different myeloid and PDC populations in the skin. And so you might be kind of attacking both populations by adding these two drugs together. So what if antimalarials don't work or you can't get access to quinacrine? There is some data to support the use of topical JAK inhibitors, and so I kind of put it at this spot. It's not really on this algorithm, but you can try to see if you can get it approved. This is just an example of a patient with some refractory discoid lesions who was put on a topical JAK inhibitor, ruxolitinib, which is approved for graft versus host disease, and she did get some benefit, including some hair regrowth with that use. So it is an option if you can get it approved. And then what if antimalarials don't work? So Vicki kind of put this algorithm into a circle, and I think this is about right, because it kind of becomes the Wild West, and pick your choice, right? So you can try adding dapsone. I find that it really only works for bullous disease. That's really where the neutrophils are most involved. If you do, if you look at biopsies of active discoid or SCLE lesions, there's really not a lot of neutrophils there. So dapsone really only works, I think, when neutrophils are involved in disease. So I don't really even try it now in my non-bullous patients. You can add methotrexate. Some patients do respond to methotrexate. You can add Cellcept. In my experience, Cellcept doesn't really work that well when patients have refractory skin disease, especially refractory discoid. Every patient is different. So it is something you can try, or you can try lenalidomide. This still is not FDA approved. I've had an issue with tolerability with my patients. I know Vicki still really likes to use it, but it's not my favorite choice. But basically, you kind of have these options if you have a CLE-only patient. This is sort of where the train ends right now. But if the patient has CLE and SLE, we do have some more options for drugs that are approved for systemic lupus, including belimumab. Whether or not calcineurin inhibitors would be beneficial, I think, is a really big question mark. And then the use of anifrolumab. And again, in systemic lupus patients, you really have to think about other manifestations of systemic lupus that need to be treated that might be more life-threatening than the skin disease first, and then the skin, we address that sort of on the back end, which is not, ideal. It'd be great if we had one drug that just fixed everything, but it's kind of the way that the practice goes. So how do we rationally choose which options to pick for patients? So again, I'll talk more about the disease pathogenesis later this afternoon, but I think there's still several caveats when we're picking drugs for our patients. Is one, we still don't know everything about cutaneous lupus. And again, the drug options are really limited for CLE only. So you end up asking companies basically to see if they will support giving you drug for patients. And so I think, the newest kid on the block is anifrolumab. And, which patients do we think we would want to try on anifrolumab if they are, kind of a refractory cutaneous lupus patient? And, just as a reminder, it's only approved for systemic lupus. It's not approved for cutaneous-only disease. But one of the things that we know is if we look at interferon scores in lesions of patients, either with discoid or subacute cutaneous lupus, and we look at whether patients have CLE only or systemic lupus, which are the black dots, you can see that the interferon score is high in every single patient. So this is actually even more interesting than when we look in the blood of systemic lupus patients, where you only see high interferons in about 70% of patients. But here in the skin, in a biopsy of a lesion, everybody has high interferon. And so my sort of rule of thumb is that it's probably reasonable to try anifrolumab in any patient with refractory disease. And the caveats to think about if you're going to put a patient on anifrolumab, you really want to try to mitigate the risk of herpes zoster. So I really try to vaccinate anybody that's willing. And even if they have to pay out of pocket, I think it's worth it, because the zosters rates were about 5% in the trials. And so I think it's important, especially if patients had chickenpox when they were kids. If they had the chickenpox vaccine, they probably don't carry that risk for shingles innately. But if they had chickenpox as a kid, make sure they get zoster vaccine. Also, flu vaccines, really important. Flu was also increased in these trials. If you think about interferon signaling, which is what anifrolumab is blocking, interferons fight viruses. That's why mitigating viral infections is so important. And any other vaccines you can get them to do, I think, is great before you start drug. And then you want to ensure a compatible medication regimen, like if they're on cyclophosphamide for their kidney disease, you obviously probably aren't going to start anifrolumab right then. And then again, insurance approval is a hurdle. For systemic lupus patients, initially I was having a really hard time. Now it's getting a little better to get anifrolumab approved, but really my CLE only patients, these insurance companies have these, excuse my French, ridiculous algorithms where, like, if you're A&A negative, they completely refuse to look at the patient. So they have all these ways to try to prevent patients from getting on drug. I have had luck going to the company and for CLE only patients, asking them to provide drug. And I have a few CLE only patients on anifrolumab now, funded by drug company assistance. So it is an option that's out there. So this is actually one of my patients who's A&A negative SCLE patient, and he failed everything. We had him on everything. We tried everything because he would get sort of like joint pain and some rashes. This isn't the most oppressive SCLE, but it's the one picture I took right before he went on anifrolumab. And he really had nice improvement in his erythema, and also these lesions were fading with this is one dose. So that was also impressive. And then Joe Marola published this case series of a really impressive improvement of a refractory SCLE patient after a single dose of anifrolumab. Again, really remarkable. When the patients respond to this, it's like everybody's high-fiving. Knock the socks off. Okay, everyone's like high-fiving. Patients are so happy because they look so much better. And then Ruth Ann Vogels published a nice case series of refractory pediatric discoid patients who went on anifrolumab. This was 7 patients. They had lupus and refractory discoid as part of their disease. They were aged 14 to 20. Again, this is not approved for kids yet. This is just a case report of some patients who got it. And the mean number of therapies that these patients had failed for their skin was 4. So this is not, you probably all see this. I see this all the time. Patients have been put on everything, and really anifrolumab is fixing them. And you can see here their improvements in their Class C scores. It's really quite remarkable. And this is another patient of mine who has more of a hypertrophic type of discoid. And she, again, had failed everything, failed Rituxan, failed everything. And she really cleared her skin beautifully. One thing I will say is that in my clinical experience, when patients stop anifrolumab, the rashes come back within about 1 to 2 months. So this is not something that's putting people into long-lasting remission. And I've had some patients who do really great on the drug but can't tolerate it. They get a lot of joint pain. I have a few patients who complain of being bedbound for a few days after the infusion. I don't know if this is a widespread thing or just happens to be patients in my practice, but their rashes do come back after they stop the anifrolumab. So we're not doing a long-lasting cure. So targeting interferons, that's our option right now. There are some JAK inhibitors, which I'll talk about, sort of pending for lupus. Nothing is approved for lupus in the JAK inhibitor space, but that is another way to block interferons if you're in need of a non-infused therapy and want to go off-label. So what about B-cell targeting in cutaneous lupus? So just a reminder, one of the things that happens when you're developing autoimmune diseases is that autoreactive B cells escape negative selection. So if they have, their antibodies that they're holding on their cell surface bind to autoantigens, they're supposed to die, right? We don't want our autoreactive B cells getting out into the periphery. So this is sort of that step here. And one of the molecules that actually overrides the cell death program is when BAFF is too high. So in healthy people, you have just a little bit of BAFF, and if you get this deletion signal when you're maturing your autoreactive B cells, they go through cell death. But in lupus, and there's not as much data out there for CLE only, but you have too much BAFF floating around. Interestingly, interferons actually upregulate BAFF. It's an interferon-inducible gene. So probably related, but you have too much BAFF floating around. And so when you get this signal from an autoreactive B cell and it says die, BAFF says, nope, you're not going to die, you're going to live and you're going to proliferate and cause bad things. And so we do have a drug for lupus, belimumab, which is a antibody that blocks BAFF signaling. So one of the things I just want to remind people about is that belimumab actually takes a really long time to work. In all of the trials, the peak efficacy takes up to 6 months. So if you're going to be adding belimumab to somebody's regimen, just know that you're going to have to keep the topicals going, or if you are using systemic steroids, which isn't really recommended, but sometimes we do it when patients are really severe, it's going to take a long time to allow for taper of those other meds and to really see if belimumab is helping these patients. And one of the things that we had done some research on was actually B cells are a prominent feature of discoid lupus. So we published this paper a few years ago where we had this was actually microarray data. How old is that? But we had compared, we were trying to see if we could find things that would help us discriminate discoid from SCLE lesions. And one of the things, nothing really came out because they had such prominent interferon signatures. When you were looking at gene expression profiles, they really looked so similar, right? So we did WGCNA analysis instead to try to find modules that would predict whether a lesion was discoid versus SCLE. And one of the things that came out was that it really was B cell genes that were really prominent in discoid lesions versus SCLE. And then we had this validation cohort where we checked this again. And again, the B cell genes were really prominent in discoid, maybe a little prominent in acute lupus, and not prominent at all in SCLE lesions. And interestingly, what we saw was that the B cell lesions were highest in patients who had non-systemic disease. So if you were CLE only, you had the highest B cell signature in your skin lesions. And then if you were DLE with SLE, you were sort of next. And really we could, dissect out pretty much all of the B cell populations were predicted to be there. And then we did some confirmatory staining on skin biopsies. And you can see again, the discoid and the ACLE had prominent B cells, but the SCLE had none. So how do we use this information to think about targeting in cutaneous lupus? So one, I don't think it's very helpful to think about using belimumab in a refractory SCLE patient. That's sort of my opinion. We don't have any data at all because in the belimumab trials, they did not collect lesional subtypes or even CLASI scores. So now we're kind of backfilling that information into belimumab's role. And so there is some data that real-life CLASI scores do improve with belimumab. However, these patients started with a CLASI of 4. So these are not like really robust active cutaneous lupus patients. And so we really need better studies to look at subtypes of lesions to understand if it makes more sense to target discoid with belimumab than something like SCLE. And then, we do have rituximab, which also is a B cell depleter. And the literature is really mixed on whether rituximab benefits discoid. Some studies support there's about a 40% response rate for rituximab in refractory discoid lesions, but then there is one study that suggested that patients flared with rituximab. I will say in my refractory discoid patients before anifrolumab, I was using rituximab pretty frequently with some good results. I had some really severe discoid patients who actually got a lot better. Now, they had systemic disease associated, so that might also be a caveat as well. And then the other thing that's kind of strange is that when we looked at our B cell data in the skin, what we saw was there was actually an inverse correlation with the presence of systemic disease and the B cell number. So the higher the B cells in the skin, the less likely you were to have antibodies or systemic disease. And so maybe these skin B cells actually have some sort of protective function against activation of the systemic immune system. So we really don't understand B cells at all in cutaneous lupus and sort of what their role is. And Naki Sands had data that suggested that, more systemic spread of discoid lesions had a more lupus-like phenotype in terms of their B cell signatures peripherally. So, there probably is a difference between CLE only and SLE with CLE in terms of the role of B cells. So this is all a little bit to be determined, but, we are seeing some patients go on belimumab, and I've had a few who actually do okay with it. So just in the last 2 minutes, wanted to briefly mention what's coming down the pipeline. So everybody's heard about CAR Ts. If you look at the data from the CAR T studies, This original case series, all but one patient had active skin disease per the patient data table, and every single patient went down to a SLEDAI of 0. So they didn't do Class E scores here, but if their SLEDAI is 0, presumably their Class E is 0, because it's all or nothing with SLEDAI, right? Everything has to improve in order to get those points. So I think the patients in these studies were getting better with their skin. These were mostly young patients, pretty refractory systemic disease. How this would work in a more like classic refractory cutaneous lupus patient, we have no data yet, but there's going to be a lot of CAR T studies coming, so stay tuned. I mean, I think it tells us that deep B-cell depletion probably does help the skin, at least in some patients. And then right now there's 2 phase 3 studies ongoing for cutaneous lupus without systemic disease. So anifrolumab subcutaneous for CLE only is currently in phase 3. And then litifilimab, which is a BDCA2 targeting antibody, which I'll talk more about plasmacytoid dendritic cells and BDCA2 in the mechanisms talk. But this is recruiting CLE only or CLE plus SLE patients into this phase 3 study. So this is also ongoing. And then there's also some phase 3 studies for systemic lupus. They all probably have active skin as part of this because that's who the patients are recruiting. They're looking for like non-nephritis, non-CNS active lupus patients. So skin and joints is pretty much what they bring. So there's deucravacitinib, which is blocking interferon signaling at the receptor. There's lenalumab, which is another BAFF receptor antibody. There's upadacitinib, which is a JAK1 blocker, which again is going to inhibit interferon signaling. And then titalacept, which is another BLyS-APRIL, which is also blocking sort of this B-cell activation. So really what's coming down the pipe is more interferon and B-cell drugs. There's a lot of more stuff in the making. If we look at the end of the rainbow, there's people looking at upstream of interferons, like how do we make the interferons? And I'll talk to you about some of our data this afternoon about why we think there's so many interferons in lupus skin. And then, there's other ongoing studies about targeting T cells, other myeloid cell populations. So these are kind of earlier phase development, but really we need more research to better understand what's happening in lupus and also how the different subcategories of cutaneous lupus lesions are going to respond to these therapies. But it's an exciting time because the companies have finally realized that it's important to collect this data. So I think we're going to get there eventually. So takeaways. Assess whether your patient has CLE only or SLE plus CLE. That's important. Sunscreen and lifestyle changes are important discussions for every visit. Try topicals first, hydroxychloroquine in everyone that tolerates. Push the dose if you can, if they need it to get to remission. Quinacrine if you can get it, if they need it. Then you can try other immunomodulators. I think anifrolumab really shows a lot of promise for our refractory patients. And then B-cell targeting therapies remain an option, but we're really not sure where they fit in the algorithm yet. So with that, I will thank you and happy to take any questions.
Thank you for that excellent talk. Any questions for Dr. Kallenberg? We do have a microphone here. Yes.
Yeah, so the question is about the combination of belimumab and rituximab. So there has been some trials that have looked. These are usually including very refractory patients, and the protocol is you basically give the patient rituximab and then you give them belimumab immediately after. I have done that in some of my patients. I think the final data from the ongoing study, I don't think I've seen that, but the early data suggested it was a pretty good way to get patients into remission. And the reason why they think that this is a good idea is that there's been studies that have looked at patients who are getting rituximab. One of the things that happens is that you get a compensatory increase in BAFF levels when you're on rituximab because you have no B cells. And so the bone marrow is like, we need B cells. And so it's like cranking out BAFF, trying to, stimulate B cell growth. So the problem is if you have some autoreactive clones, that BAFF could push, development of autoreactive B cells is one of the things that repopulates after Rituxan. So the idea would be get rid of your B cells and then add belimumab and keep the bad B cells from coming back. So I think, how to use that or which patients to select, I think, for skin only, it's a pretty aggressive regimen. I think, I wouldn't want a patient with just like one discoid lesion to go on that, but systemic wise, I think I've done it in a few patients and it has worked for a couple. I think, how good the data will be, I think we're still waiting, but yeah, that's an option. Thank you.
Yes. Question?
Yeah, so so the question is about removing antidepressants if a patient has CLE and whether you're concerned about drug-induced. So I think, if it's a patient who has really obvious like SLE with, Smith and all these other things and has cutaneous lupus and is on something like Wellbutrin, I probably would be less likely to blame the drug. But if it's a patient that comes to me, has been on Wellbutrin for a couple of years, I'm just picking Wellbutrin because I know that's one that's definitely associated with CLE. They've been on it a couple of years, they're ANA negative, they might have had a photo exposure or something, and now they've got these lesions. I would have a conversation with them about either trying to switch to a different category of antidepressant, and like involve their PCP. Like I wouldn't do these drug switches myself. Like I think we have to have a team discussion about, whether we should try, if a patient, is like very severely depressed and suicidal and has all these things, the risk of switching antidepressants is higher than if they're just, a little bit of anxiety and depression, and we could probably toy with that drug. So I think each patient is a case by case basis on like how aggressive I would be about stopping it. But I've had some patients where we've done it and I think it's helped. Yeah, it's always hard when it's drug induced, right? Because you don't, like there's no test. Like they might have a histone antibody, they might not. And so you're just trying, you got to kind of use your spidey sense to see like, does this make sense? Like, does this patient have like a really lupusy phenotype, or like, were they fine and now they're like 50 and all of a sudden have this rash that makes no sense? Like, why did they suddenly get this rash? And, with drug-induced disease, it doesn't have to correlate with timing of the drug. It can happen anytime, right? So if you're trying to like avoid like hitting them with major immunosuppression, it might be worth trying to withdraw that type of medication for 3 months and see if their rashes get better before you would go like to more immunomodulators that are going to require lab draws and they're immunosuppressing them and all those things. So, and again, some patients are very reluctant to stop those drugs, and that's just something we'll treat through it then, if that's what they want to do. So I think it's just, you have to go case by case. It's a good question.
Shoma.
Yeah. Yeah, I kind of glazed over that in Vicky's thing. So you can add chloroquine instead of quinacrine. It just has such a higher risk of retinal toxicity. So the question is, could you switch from Plaquenil to chloroquine? You could switch. I'm not sure that we have any data that that's going to be more beneficial than just pushing the dose of hydroxychloroquine on its own. And because chloroquine really has such a high risk of retinal toxicity, I really don't love using that drug. I know of like 2 patients in our whole lupus cohort at University of Michigan that have been on chloroquine at some point. So yeah, I tend to avoid. I just tend to push the Plaquenil level first. Instead of switching to chloroquine.
You mentioned you do follow hydroxychloroquine serum levels. Is that an in-house test that you have at University of Michigan, or do you send it out?
I think it gets sent out to Mayo.
Mayo, okay,
I think they're looking at actually, because we send so many now, and it actually became a quality thing that we are implementing. So I think they're going to develop an in-house test for us.
And when you're measuring that, what is the range that you're happy with? And when you're at the higher end of that range, I think you mentioned around 750 milligrams per deciliter.
Yeah.
Are you comfortable keeping patients there, or do you try to do that high end of the range for just a limited amount of time?
Yeah, so Michelle Petrie's data suggests that if you stay under 700, your lifetime risk of retinal toxicity is low. So I think in like the efficacy, that paper suggested 750 was sort of the sweet spot to get patients who were refractory into remission. So my goal is, if a patient's responding, I try to keep them at about 450, 500-ish level. If they're refractory, I might, for 3 months, like push them up a little bit and see if they get any improvement. and then pull them back for like remission. If they don't improve with the higher dose, I pull them back and say, you know what, we tried, this just isn't going to be a strategy that works.
Okay.
Yeah.
You mentioned the importance of sunscreen. I feel like I have a lot of patients with lupus, dermatomyositis, who work in offices and complain about these indoor lights, incandescent lights, I'm not sure the name of them, that they aggravate their skin disease.
Yeah.
And I'm just wondering if you have that same experience, if your photobiology research supports that there are certain types of indoor lights where, can be sort of like that same activating.
Yeah, so fluorescent lights can release UV. And so I think that's real. I have a patient who we had to find her a dentist that practiced in third world countries and was comfortable doing dental work without lights, because anytime they would put a light in her mouth, she would desquamate and just like lose all of her mucosa from the light in her mouth. And there's case reports of people like leaving the lid open on a photocopier and like making a photocopy and getting a flare of cutaneous lupus. There's several case reports of people doing those gel lamps. So I think there's ambient UV exposures that people can get. So I tell my patients sunscreen 24/7 every day of the year, and if you need to wear a hat in your office, wear a hat in your office. But I think it's real. I think I'll show some data this afternoon that the high interferons in the skin, so if it's a really interferon-driven patient, what the interferons do is actually lower the threshold for cell death and inflammation in response to UV. So we can actually trigger in tissue culture a cell death response if you prime with interferons first for about a 10-minute sun exposure equivalent. So it really lowers like how much UV you need in order to start things going in the skin. Yeah.
One more question. Go ahead, Shoma.
Yeah, so chilblains, so I try Plaquenil first, warming, and it depends how severe it is. If it's temporary, it's coming just in the winter months, we can kind of usually get through with those entities. I've used JAK inhibitors in a few patients based on case reports that are out there. They do work. Getting them approved, you got to be a little creative because chilblains is not an approved indication. But I think, probably interferon blocking strategies is useful there. And then lupus profundus, I think that's probably more of and I'll show some data this afternoon that, T cells, it's a little bit controversial, like how much of a role they're playing, but I think in lupus profundus, it's a much deeper dermal inflammation. And I think their T cell targeting therapies like methotrexate and CellCept actually can be pretty useful. It's when you have the more superficial types of disease where it's more of the skin itself is involved in sort of driving interferon signaling that seems to be more refractory to things like methotrexate and CellCept. So for profundus, I usually try CellCept first, and that, if they fail hydroxychloroquine, that's sort of where I move for those patients. But yeah.
Thank you very much,
Yeah,
Dr.
absolutely.
Kellenberg. Welcome back, everyone. We'll get started with our next lecture. It's a pleasure to present Dr. David Fiorentino. Dr. Fiorentino is Professor of Dermatology and Associate Residency Program Director at Stanford University. He directs the multidisciplinary skin disease clinic, along with Lorinda Chung in rheumatology and a complex medical dermatology continuity clinic. He's interested in the role of cancer in autoimmunity, and he studies autoantigens and their roles in the pathogenesis and classification of dermatomyositis, systemic sclerosis, and conducts clinical trials with novel therapeutics for these diseases. And he's going to present for us this morning an update on treatment of dermatomyositis. Dr. Fiorentino.
Thank you. All right, good morning, everyone. Let's see. All right, so thanks for the introduction. Thanks for asking me to come and speak at this meeting, Tony. We were just talking about that. Cleveland's a great place, so I got to go wander around and take a look. Okay, so I'm going to cover some, it's supposed to be an update on treatment, so I kind of, my talk's going to be a little bit more weighted sort of what's coming, but I will spend the first half or so just talking about how a little bit about management of what we have now. Does anyone know what this is on the first slide? No, everyone knows. The heliotrope flower. Okay. Okay, this is my disclosures. Oh, sorry, left is forward. Okay, so before we start, before we jump into therapy, much like Dr. Kallenberg was talking about, there's a few things you have to think about before you start administering medications, as most of you know who are all who are medical dermatologists. And I think the rheumatic diseases are a little different in some sense because there's this concept of damage on the skin that's really kind of a big component, and not only on the skin but elsewhere. So I think for DM, one of our hardest things that we do when we're treating is trying to figure out if the disease is actually active, especially when you're dealing with patients who are weak. You know, a lot of times, even if that weakness is due to myositis, it may be due to myositis, but now there's just, it's burnt out, and, you know, you have muscle atrophy, et cetera, and you can throw all the immunosuppressants or medicines you want at it, and nothing's going to happen. Patient may do better with physical therapy. So the same is with the skin, though. So, you know, you have to kind of try to assess, are we dealing with telangiectasia, that's kind of that's the remnant of the inflammation, or do we have active disease? The other thing is that this is the disorder that's characterized by a good chance that there may be an internal malignancy or a presence of internal malignancy, and that may obviously influence your systemic treatment decisions. And then it's a systemic disease. We're dermatologists, but obviously we have to be thinking about the other organs, and it depends what organs need therapy, what therapy you select. How bothered is the patient by skin disease? That's actually a really important one. I mean, I get a lot of referrals to our clinic with the patients. Maybe they have a little erythema over their knuckles, and they're on 3 medicines, and you know, and they're referred because they've got recalcitrant disease. But the thing is, I mean, the patient's not even bothered by it, and so I think hand in hand with that, sometimes complete remission of the skin disease, it may not even be the goal of therapy. I have a lot of patients running around who are a little red, and so you have to kind of weigh the risks and benefits. How far are you going to try to push your treatment? And there's no algorithm, unfortunately. Sort of like Michelle was saying, it's a little the Wild West, not as Wild Westy as the cutaneous lupus, where there's literally Plaquenil and then you have a bucket. I think it's a little bit less that way, but it's similar. So again, before you treat, not as much with lupus, but there are meds that induce DM. We all learn in medical school about statins, and now we've learned, right, statins are behind a whole nother class of autoimmune myopathies that we don't really even see as dermatologists in clinic. And I'm not convinced. Maybe 1 or 2 patients, you know, give a good story for their statin, maybe being given around the time they got DM, but much more commonly, you're going to see in my clinic now, in the age of PD-1 inhibitors and are the checkpoint inhibitors for cancer. That definitely can induce dermatomyositis or DM-like disease. And I've personally, unfortunately, caused some DM with in my earlier years with TNF inhibitors, and I have had patients come in being treated for what looked like RA with a TNF blocker and then develop dermatomyositis. So those, I would say, would be the 2 classes of meds you want to be making sure your patient, you want to at least know that may be impacting the presentation. Okay, so update on therapies. There it is. There's the update. That's our long list of FDA-approved choices that we have. You know, it's probably where lupus was 10 years ago. We got 1 drug, IVIG, which is great, and that was approved in 2021. There's basically an ACTH or analog, Actar gel, which doesn't get used a lot nowadays. But you know, so the question is, what do we do with what we got? So Okay, so this is just the data from the IVIG trial, since we have very few New England Journal of Medicine articles on the treatment of dermatomyositis. Interestingly, 2 NEJM articles, both on IVIG and DM. One was many, many years ago, and then this particular one. And just the points here I want to make is it works well on the skin. There's a post-hoc analysis that was done that basically the skin disease response looks similar to this. This is what's called the total improvement score, which is sort of an amalgam of muscle disease, extramuscular disease, and some other kind of assessments. But basically, it was a randomized placebo-controlled study. You can see in the treatment arm, treatment's fast, so that 4 weeks, that means that that's the evaluation before they got their IVIG. So the IVIG was at 0 weeks, 4 weeks, 8 weeks, 12 weeks. So they'd only had 1 dose of IVIG, and you can see there's a pretty good response. And you can see, so if you don't have a response by 8 weeks, or definitely 12 weeks, your patient's probably not gonna respond. So quick responder, very clear data. And I'll talk a bit about IVIG in a sec. I just want to give this, so this is sort of the overview of where we are today. So with the toolbox you have in hand, this is the world according to Dave, treatment of dermatomyositis. And sort of the red pluses are the things we really like to use in the clinic, we think are very effective for these particular organ systems. So antimalarials do not play, in our practice, do not have the same role that they do in a cutaneous lupus patient. So they can be effective in I would say a minority of patients. And the other issue with antimalarials that is seen in some centers but not in others, but some centers have noticed that there is an increased incidence of patients having an intolerance to antimalarials, either have a cutaneous intolerance, so either a hypersensitivity reaction or actual worsening of DM. Of disease. So that's something that's maybe a little bit peculiar to the DM group as opposed to cutaneous lupus. Prednisone, you can see we use a lot of prednisone in the clinic because our patients have systemic disease. We use it a lot for muscle disease, joint disease. Methotrexate, I think, is being used less and less in our center. We tend to use it mostly in patients who have inflammatory joint disease. We don't really use it in the ILD patients, of course, and it can be helpful for skin and muscle for sure, and in the right population, in the right patient, we still will reach for it, but we tend to reach now more for CellCept, for skin and muscle disease. Probably I would call that, sometimes it can be a first-line agent, first-line systemic agent for skin disease. Azathioprine, we use mostly for muscle in our clinic, and again, not super commonly. IVIG, I would say, is sometimes it can be first or second line. So we use a lot of IVIG. That's why I want to talk a bit about that. Rituximab, you can see, great for muscle and joint, really great for joint, often good for muscle. And the lung docs, there's actually accumulating data that rituximab for connective tissue disease-associated interstitial lung disease can be very effective. So that's another one. And then we have some of the other more rarely used, including the JAK inhibitors, which I'll touch on. So I just want to mention IVIG because I think that if you don't use, how many people use IVIG? I'm just kind of curious. That's a lot of people. How many people don't use IVIG? Maybe that's a better question. It's okay. You can raise your hand. Okay, yeah. So that's good. So most of you use it. For DM, I think this is just such a great treatment. It really, it acts rapidly. You can almost use it like a prednisone sometimes to get disease that's really, really active back into control. We tend to use it if a patient has a malignancy. We would rather choose IVIG rather than something like mycophenolate or, where we're a little bit more worried about immunosuppression. The main thing, couple things that just to remind, if you're using, or if you're gonna use it, you gotta infuse slowly. So that's just like probably the most important thing. Like the companies, especially the home nursing companies, those nurses want to get out of there, right? So they come to the patient's house and they set up that thing up, they crank it up to 250 cc's per minute, right? And they're out in an hour and a half. And so all you have to do is ask the patient, how long did the infusion take? Because they come in and I say, how was your first infusion? They say, I had the worst headache of my life for like 3 days. And then you find out that the infusion took about an hour. And so, I now just write out 0.04 mils per kg per minute max. And so that's just a number that's a helpful one to think about. The home infusion is a good option because it's a pain for the patients to come into the infusion centers. But you just have to, keep those nurses in control, and make sure they're infusing the way that you would like to be infused. Headaches, cyproheptadine. I don't know if any of you use that, but it can be super helpful pre-medication to help, especially this IVIG headache. I've found it very, very useful. And then things to watch out for. Mostly the things I'm thinking about are thrombosis. And hemolysis. Abject hemolysis is rare. Usually you're not going to get someone who's going to come in with brown urine, and I've had one patient like that. But there's often a low level of hemolysis, very low level if you look for it, but it's nothing that's clinically significant that you need to worry about. It's very, very low level. And you can use subcutaneous IG if they don't tolerate intravenous. So most of the other agents you're used to using are, Cellcept and methotrexate. I'm not going to talk too much about, but that chart hopefully helped you a little bit know about how we sort of think about the medicines. But I want to just spend a little bit of time talking about what's coming or what has recently been tested in DM. So this is a reasonably complete listing of all the targets that are being looked at in dermatomyositis and the specific agents that have actually been just recently conducted in a clinical trial, are currently being conducted, or are planned. The yellow means the trial was completed and it's like, maybe, maybe not effective, not sure. The red was like a no-go, it was a negative trial. And then the green means that we have some positive data that probably means that they're going to be, they're looking like potentially very, very effective therapies. So T-cell therapies, unfortunately, so far have not really, we have a little bit of data on abatacept that's actually conflicting, and no data that abatacept helps skin disease in DM. And then beyond that, there's really not a whole heck of a lot. If you think of a calcineurin inhibitor as a T-cell blocker, which it sort of is, then you could say, yeah, we know we use tacrolimus in patients with DM, at least for their interstitial lung disease, and it can be effective. So there's a role perhaps for that. Other than that, there's not a lot on the T-cell front that is looking super promising. B cells, like Dr. Kallenberg mentioned, also very promising in dermatomyositis. And so I'll talk a little bit about rituximab and CAR T therapy as well. PDC, I don't know that we've talked too much about PDCs today. Those are plasmacytoid dendritic cells. A while back, everyone thought this was going to be, the PDC was going to be the solution to all interferon-mediated diseases. I actually never really thought they were going to be, to be totally honest with you, but there's still companies that are pushing this, so we'll see if the PDC, certainly in lupus, litifilimab, looks like a really interesting agent. So it may be that there's a role for PDCs. We just don't know, and there's a couple of trials that aren't direct. The daxdilimab is a direct PDC killer, and Padran is a toll-like receptor blocker, which is, TLR7 is most highly expressed on PDCs, so it's definitely designed to block largely PDC function. So if you ask what's a PDC, I have pictures later so we can talk more about it. And then on the right are the non-cellular therapies. So autoantibodies, this is a new class. This is going to be a new class of therapies for DM. So if we get rid of the autoantibodies, what's happened? Complement blockers, JAK inhibitors, and interferons, and then some other mechanisms I won't get into today. So again, you can see where a lot of the green are. B cell, interferon, that sounds familiar from your prior talk, and then JAK inhibitors potentially. So I would say if I had to pick, those are the three areas that look the most promising. Okay, so autoantibodies. I just wanted to mention this, this class of drug because it hasn't come up yet today. These are these neonatal Fc receptor antagonists. They haven't really made their way, the neurologists know all about these because, they're approved for myasthenia, or the hematologist for some hemolytic disease of the newborn. But basically, the idea is that is to decrease overall antibody levels in the blood. It's almost like doing a pheresis or something, or a plasma exchange, where you're just going to basically lower autoantibodies with the thought that maybe some of these autoantibodies in dermatomyositis are literally pathogenic, which we really don't know yet. But that's why the result of these trials is going to be very interesting just from a biologic science standpoint, because if some of these agents are effective for myositis, it really does pretty much prove that these antibodies are pathogenic, which everyone always asks me when I give an autoantibody talk. So the way these work is imagine that cell is an endothelial cell that's lining the blood vessel. The top side is the lumen of the blood vessel. And, the cells that are in the connective tissue, they need to get albumin and protein nutrients from the blood. So they basically are constantly penocytosing these, from the blood. And when they do that, they pick up a lot of the antibody that's in the blood, right? And so you want to save that antibody. So this neonatal receptors in yellow binds the antibody and recircles it back and gives it back to the plasma, so you don't deplete your antibody levels. So you can imagine if you have an agent that blocks that binds to that yellow and competes for that antibody binding site, then you're going to slowly deplete the recycling mechanism and deplete the antibodies. So that's the idea of how they work. The two drugs that are being tested right now are efgartigimod. That is on the market right now for myasthenia gravis. And then nipocalimab, which is on the market for a hemolytic disease of the newborn and babies. So both those trials are pretty large. They went right in. They're going for it, phase 3, and we'll see if they can ever get these things enrolled. It'll be interesting to see what we see, but that's going on right now. The PDC I mentioned. How is it that we have bugs in here? Aren't we like 300 feet under the ground? This is a first for me. Can you see this fly, or do I look like I'm crazy? Okay. All right. Okay, so this is just the plasmacytoid dendritic cells in green here. The plasmacytoid dendritic cell does a lot of things, but one of the things it does a really good job of is producing type 1 interferon. And type 1 interferon, much as is the case with lupus, seems to be a linchpin, a very key regulator, mediator of myositis, both skin and muscle disease. And so these PDC inhibitors are the two that I mentioned. One's actually a surface molecule that binds to a surface molecule, kills the plasmacytoid dendritic cell, and the other one's this toll-like receptor 7 inhibitor that blocks, if you bind to TLR7 and block its function, you'll inhibit interferon production from the PDC. So I'm just mentioning those. They're in trial. Again, we have no data. Okay, so what about some things with data? So JAK inhibitors, we all know about JAK inhibitors. Incredibly complicated set of kinases that binds to a number of different receptors that are involved in signaling, growth factor receptors, immune activation. In yellow, the one shaded in gold is the interferon gamma, interferon alpha, interferon beta receptor. That's felt to be probably the most important signaling receptor with regards to myositis. And so you can see I just listed a bunch of types of JAK inhibitors, and you can see basically pick your JAK inhibitor, and you can have an X in the box of the receptor you want to block, basically. So there's pan-JAK inhibitors and JAK1, JAK2, which is baricitinib. That's in a couple of trials in Europe for myositis right now. Brepocitinib, which would block all the receptors that I've boxed in green. So it's basically saving you from the hematopoietic side effects. So it's a TYK2 JAK1 inhibitor. Very interesting agent. Actually, the one thing I'll mention about this agent, they also went right for it, phase 3. they actually are the most successful. They are successfully enrolling their trial. So I think if we're going to get data back from any of these large trials, it's probably going to be this one that's going to be the first, the earliest data. And so you're still talking probably a year, over a year from now, but that's better than some of the other trials, unfortunately, that are enrolling, which is another whole issue in myositis, is finding the patient population to test. And then there's another agent, this GLPG, which is a straight TYK2 inhibitor. So that's pretty much, that is what's happening. Those are the agents that are being tested right now in myositis. Now, what about other JAK inhibitors? What data do we have? So tofacitinib is the one we use most in the clinic because it's available. It's hard to get. When I say we use it most, it's not like we're just giving it to everybody. But if the patient's got inflammatory arthritis, we can get it approved. Or if the patient's about to go on IVIG, I'll threaten the insurance company that I'm going to put them on IVIG, and then they say, oh, maybe tofa is going to be a better way to go. So this was an open label trial, 10 patients out of Hopkins. On the left is that total improvement score. And then on the right is actually what's called the CDASI, which is a measure of skin activity in dermatomyositis. And you can see that this open label study conducted by rheumatologists for skin disease, which was great, showed very promising effects. We use it in the clinic. Certainly can be very effective for skin disease as well. That I found. So data on baricitinib in adult DM. This is a open label trial out of China, 2 milligrams BID dosing, and you can see that there was actually nice effects. On the left, again, is that CDASI score, so that's a straight skin score. On the right, actually, they did this interesting Visia. They used this Visia machine where you can quantitate redness, and again, showed that they had a nice response. Some more data in juvenile dermatomyositis for baricitinib, all positive data, basically both muscle strength and skin disease. So I'll move through that. So that's super exciting. And so we'll see what happens with these JAK inhibitors, but right now it's an off-label game that we have to play to try to get them. Okay, what about complement? So complement is interesting because one of the first studies that was done, ultrasexual studies of muscle in DM or in myositis, DM and PM, showed that in dermatomyositis, right, there's deposition of complement in the muscle, in the vasculature, this membrane attack complex, and that's like in 1990. So it's been like 30 plus years that people really don't understand what is the role of complement in DM, because no one's really done a good trial of a complement inhibitor. Some people theorize that IVIG works so well because it binds complement and inactivates the function of C3. Although others believe that it works by that neonatal FC receptor mechanism that I just mentioned. So there's a lot of interest, but no one really designed a trial and actually executed a trial until now. So there's two that I know of, and these are the different complement pathways that I never remember, so don't ask me about them. I can't remember this pathway for the life of me. It's like porphyria. This one and porphyria, forget it. But the ravulizumab is a C5 inhibitor, so it's right at the end of the cascade. You would think that's going to block that membrane attack complex. But they did a trial in dermatomyositis. Didn't publish anything, but if you read the investor news, they canned the program. So I don't think it was a positive study. That's just my power of intuition. I'm pretty good that way. So I'm thinking that probably what didn't look good. So unfortunately, that looked like a failure. But there's another agent on this ARGX that's going to be in a trial in a few months. That's a C2 inhibitor. So, and then there's some other companies looking, kind of dipping their toe into the complement world. So it's not dead yet, but so far the C5 inhibitor was a bit disappointing, I will say. Okay, what about type 1 interferons? So this is just a schematic showing you that type 1 interferons are extremely important. You know they're important, right? When your body makes about 20 different kinds of type 1 interferon, you have lots of redundancy in this system, probably one of the most important signaling systems that we have for antiviral defense. They all bind the same receptor, and that's what Michelle already talked about anifrolumab, right, for binding the type 1 interferon receptor. There is a trial that's being planned in DM with anifrolumab, and there's some, I have no personal experience using anifrolumab in DM, but the importance of type 1 interferons would suggest that it would be effective. Now, there was recently a phase 2, currently in phase 3, trial of an anti-interferon beta based on some scientific evidence in the skin and blood that maybe beta is the key interferon that is going to be behind all of this disease activity. So maybe blocking beta, obviously lots of potential pluses to that. Michelle mentioned when you block IFNAR, if you block all those type 1 interferons, zoster is a big problem, reactivation of herpes viruses, in addition to other infectious issues. So this one will keep that pathway largely intact. You're just blocking beta, which is really coming largely from non-immune cells. So very interesting biology there. And so there's the type 1s, and then beta is just one of them. So this is the phase 2 that was already done. The data's in. It's called dazukibart. I'm not sure if that's how you pronounce it. But it was tested in just for skin disease initially, for dermatomyositis. So it was randomized, double-blinded, 2 different doses of dazukibart, placebo-controlled. And you can see the trial was really well conducted. Placebo response is like almost nil, really low placebo response, and a very impressive skin response. So we worked on this trial. I'll say that I've never seen patients have response like this ever to any agent, ever, period. I had patients go into remission on this drug who have been on multiple medications. So they got dosed three doses, week 0, week 4, and week 8. And many of the patients stayed in remission. I still had them a year later, and they were still in remission. So super exciting. It's in phase 3 right now, so we'll see where we end up with that one. But if you define responders as like CDASI responses greater than 5 or CDASI decreases by greater than 40%, you're talking about like the vast majority of patients respond to this medication. Better, so that data is stronger than IVIG for skin. And it may improve the myositis. This is the total improvement score, which is that one I mentioned involves muscle, extramuscular, but it's largely muscle driven. And there is a hint of an effect, but it was just underpowered. They enrolled a myositis cohort right there at the end. And so I think the phase 3 is really going to give the definitive answer on does it work for muscle. Okay, I want to finish with B cells. So we all know rituximab. Okay, there's this, one of the largest trial, double-blind, placebo-controlled trial ever done was the Rheum study, Rituxan and myositis. This is like over 10 years ago now. And it was it wasn't placebo-controlled. It was basically like the control group got rituximab late instead of early. And the idea was you should see if it works, you should see a separation in when patients improve. The people who get it early should improve first, and the people who got it late should improve after. Well, it didn't work out that way, unfortunately. But you can see the bottom line was most patients improved, though. They just didn't separate it large. The time period interval between the 2 cohorts wasn't large enough to see a separation. But the problem with rituximab is it doesn't really work on all the patients. And on our experience, it's not that effective for skin disease for most patients. And the question was why? And we thought we knew, well, B cells just must not be that important for skin disease. And maybe in some patients they're important for muscle, but not others. And then this whole concept of, well, perhaps we were missing the boat because we were looking in the blood. And it looked like the B cells were depleted in the blood, but they were still in the tissue. And we know that now, that rituximab is not a deep depleter. And so hence, again, CAR T therapy, where you can design these T cells, right, to do anything you want. In this particular instance, most of the CAR T therapy that's been, the only CAR T therapy that's been published in autoimmune disease is CAR T therapy where the receptor is directed against CD19, which is a B cell surface agent. So the idea is engineer these cells to really get rid of the B cells. And then the idea is, right, as it was discussed in the last lecture, B cells, we all have B cells in our periphery, unfortunately, that could be potentially reactive. against self-antigens. It's just that they're kept in check and they're not being activated. But in autoimmune disease, some of those B cells are getting activated to make antibodies and do other things, present antigen, which is probably also a very important function of the B cell in autoimmunity. So the idea is kill all the B cells and then let the body reset and establish a whole new repertoire of B cells and hopefully put the patient back where they were before they broke tolerance. And so, I'm not going to go over this, but basically you all know about CAR T therapy, but it involves a very laborious process of taking cells out, engineering them, and then putting them back in. But I want to just show you some data. So this is one of the first. This is data on a patient who is a JO1 positive patient. They did have a rash. But they didn't talk much more about what that rash entailed. And this is a CK, and you can see the CK is bouncing up and down. This is before they got CAR T therapy, and they're being put on all these potentially toxic meds, Cytoxan, rituximab, MMF, and they just keep bouncing around. Their disease just is not controllable long term. So they get CAR T therapy, and this patient's pretty representative of what you see with CAR T, anti-B cell CAR T therapy, is that the B cells go away. That's the ones in orange, and they're gone by like 2 weeks. You can't see the B cells anymore in the blood, very fast. And then they tend to repopulate over the course of, some people repopulate most of their B cells in maybe 100 days, so that's 3 months. Some people take a year, so there's a many-month process for the B cells to repopulate. And the CAR T cells peak after about 10 to 14 days, and then you really don't see them. You can't detect them in the blood, at least. You can't detect them after 20 days or so. Okay, so this is what about the response? So this is her CK, and you can see the CK just dropped right down, very quick response. And these are other measures of activity, which basically, this is her strength. It went up to a full muscle MMT of 150 is full strength. And basically, this person went into complete remission off meds, stopped their glucocorticoids, stopped all their immunosuppressants. I just like this because it's a really cool way of looking at muscle disease. This is called a FAPI PET CT scan, which is an interesting way of tracking active muscle disease. And you can see it's in blue, and you can see all the proximal inflammation, and then it's just gone after CAR T therapy. And then this is just, most of you probably read this article, but it's sort of the synopsis of the German group, their experience using CAR T, anti-CD19 CAR T therapy for autoimmune disease. These are the 3 patients with myositis that have been treated. 2 were JO1 positive, 1 was NXP2 positive, so a straight DM patient. All of them had a major response, basically remission. All of them got off their steroids. All of them got off their immunosuppressives so far. I was mentioning to Tony last night that there was 1 relapse. We can talk about, there has been 1 relapse of one of these patients, though. So again, all 3 patients, you follow their CKs. They drop down very quickly. All of them get strong again. And this is just the response, considered a major response. All of them moved into a major response. That moth is just thinking about it. It's thinking about coming back. Okay, I think I'm gonna just skip through that. So I'm gonna. That's the talk. So basically, where are we with all of this? Probably very similar conclusions to the lupus trial. A lot of these agents are the same ones being tried. But like I said, interferons, B cells, that's kind of where it's at right now, unless we get some other really interesting surprises from the complement studies or the autoantibody studies. I think one of the big worries right now, if in the field, is that all of these trials, you can only be eligible if you have active muscle disease. So as we know, and Rick Sontheimer is going to talk about this afternoon, there's a huge chunk of patients, or non-insignificant chunk of patients, that either never experience muscle disease and have bad skin, or maybe have both in the beginning and then the muscle disease controlled and they're walking around with skin disease. None of those patients can get into any of the trials. Not a single trial that I showed you would enroll any of those patients, would allow someone to come in. They have to be weak to get in. So that's a problem in my opinion. The other thing is right now the trials go down to age 18, so we're not really enrolling a lot of juvenile patients, which I think is a typical issue as when you first get into a disease. And then if you have a history of cancer or you're cancer associated, for obvious reasons, the companies don't want to be enrolling those patients. But it's true that is still a group of patients that need therapy. And so, those are challenges to find, to know where are those patient groups going to end up as far as access to the therapy ultimately. And then, this isn't a super common disease, right? So the other thing is just like, are we going to be able to keep finding these participants who meet all these very, very strict criteria for these 200 patient trials, right? In a disease that's, there's maybe 20, 30, 40,000 in the US total. I'm a little worried that the well's gonna run dry, and we're getting what we asked for, which is pharmacy is interested, industry is interested in these diseases, which is awesome. But the worry is, can we deliver? Are we going to be able to enroll these trials? So anyway, with that, a little bit of a negative Nelly ending, but the bottom line is I'm actually I'm very encouraged, and this is a really, really cool time. I've given a lot of talks on treatments, and I've never been able to give a talk on like trials in dermatomyositis. So this is like really a brand new thing. So anyway, I'll stop there and take questions. Thank you.
Thanks, Dave. Questions for Dr. Fiorentino? Shoma?
Comments about MDA5 skin lesions, the
How to treat it.
ulcerated skin lesions, and how you manage.
Yeah,
And the role of apremilast. Has there been any data on that for cutaneous dermatomyositis?
Yeah, so okay, so I don't need to repeat that because you have a microphone. So the first question was about, what was it about? Oh, it was about the skin lesions of MDA5, the vasculopathic lesions. How do we treat it? So in our clinic, we usually start with, to be honest with you, I find that the PDE5 inhibitors are really can be really effective for that. So sildenafil and the like. So if the patient's coming in, they may not, a lot of them don't have frank ulcers, but they're going to have really tender, painful fingers, right? They're going to have these lesions that are just, they really bother them. They're really, and I found that I think it's largely an ischemic phenomenon. There's inflammation there as well. But so sildenafil, we sometimes use aspirin, pentoxifylline. We try that. But if the patient's got really bad lung disease, we have to cyclophosphamide has been helpful for it, but we're not, that's just because we were treating something very bad lung disease, and these got better. So I would say, aspirin, pentoxifylline, maybe cilostazol, those would be, but I start with a PDE5 inhibitor for that. And then the question was about, I'm very tired, sorry. The question was about apremilast. Yeah, so we did an open label study of apremilast looking at skin disease in DM about 10 years ago, and it was totally negative, unfortunately. We never published it. It's on there on clinical, the data's on clinicaltrials.gov, but we never actually published it, which we should have. There was another open label trial, which was a positive trial more recently. I think it was in the last maybe couple of years, looking at apremilast. So I'm not a huge fan of apremilast. Patients just don't tolerate it that well. So we, and it's expensive to get that approved. I might as well, if I'm going to lie and say they have psoriasis, I might as well get a good one and lie and say, okay, they got psoriatic arthritis, I'm going to give them something else. But I mean, I'm kind of joking, but yeah, so I don't use a lot of apremilast. We didn't see it was that effective in our trial, so I don't think it's got a lot of efficacy.
You mentioned zoledronic acid listed as a medication for drug-induced dermatomyositis. So what is your go-to when we're treating them with high doses steroids to prevent osteoporosis and fractures?
Yeah, I think, so that is a report of zoledronic acid. We do not use that data clinically, like, oh, I don't want to put a patient on zoledronic acid because it's going to flare their DM. I was just listing that, but yeah, it's a great question. It's based on just, yeah, that's good to clarify, though. We definitely, the osteoporosis prevention, much more important than worried about this case report of flares.
Okay.
And then you can take over.
Then you can moderate.
Management of calcinosis in dermatomyositis. You know, there's some emerging data on JAK inhibitors, mostly from Hopkins. And any comment?
Yeah, yeah, it's really a tough problem. I mean, it really, if there's one unmet need, it's that we need to address. It's the calcinosis. I think that it's possible that the way I think of it is that the juvenile DM calcinosis may be different than the adult DM calcinosis. So, you know, there's where I was training, we were taught, well, all you have to do is just prevent the active disease, and then you won't get the calcinosis. And a lot of that was based on the JDM literature, right? And that may or may not be true, but and so I think that the people who kind of are pushing that are used to treating, it may be just a different disease in the pediatrics. So yeah, if you prevent all this, you can prevent the calcinosis. But we have so many patients, right, who have calcinosis that just doesn't seem to respond to anything. I haven't really, I mean, that's the JAK inhibitors. I don't know. I don't think they're any different personally than probably any of the other anti-inflammatories. Sometimes you see a couple, like for a while there, I thought leflunomide was the Lord's gift to calcinosis cutis because I had 2 patients respond, then I had 10 not. So I think in the right patient, if you block the inflammatory pathway, you may get lucky. But I don't think the JAK inhibitors personally are any better than any other. We struggle with it just like you guys do.
Have you ever tried IV sodium thiosulfate?
Yeah.
Yeah. No. I haven't had any response.
For me, I haven't. We've probably given it. We've given it to like 10 patients. We made like 5 of them sick, so they couldn't stay on it. But the other handful just, I mean, we just didn't see anything. I mean,
Yeah.
so you know, some people inject sodium thiosulfate. Yeah, I think if they're really small lesions, maybe you could inject them, but it, you know, it's, as you know, it hurts a lot to inject it. So I just don't know that I have any. You know, we still just excise them. It's very, when we can, very low tech.
You mentioned hydroxychloroquine, and you know that it's, and I agree 100%. Like I don't think it's very good for dermatomyositis. I typically will still add it on. I guess in my mind, I think, well, if it does anything, maybe it's going to minimize the dose of other immunosuppressive agents they need. Because as you mentioned, a lot of these patients, to control bad skin disease, they're on multiple immunosuppressive agents. So I'm just curious, do you use a lot of hydroxychloroquine or not?
I use some.
Okay.
That's, I would say it's the minority for sure of patients. And again, it's just I don't know why we have this experience that these patients just can't tolerate it. Their disease, either their disease flares massively or they get a bad rash. I mean, not everyone, but we've had so many of those that I've just kind of, I just kind of done with it. But you're right, it can be helpful in the right patient.
But mildly, I think at best.
Yeah.
And for IVIG, when you're treating your patients with IVIG, do you have an end goal? So in other words, do you give them IVIG for 6 months? How do you use IVIG?
No, yeah, I don't have an end goal, which sounds bad, but
No.
I don't. It's not like steroids where I'm like, okay, I have to have this patient off in X. You know, I really want to be. So some patients, it's the only thing that keeps them going, right?
Yeah.
And so there's no real reason, in my opinion.
Yeah.
There's no reason. Oh boy. There's no reason to. There's no reason to pull them off the med.
Yeah.
You know, unless they're not tolerating it or something like that. Yeah, so we have patients who are on, I'm sure just like you, years of IVIG.
Yeah.
And usually if they're going to get a thrombotic event, usually it happens early, after the first few infusions. Not always, but that's usually, so it's not like, I don't think they're accumulating risk of a thrombotic event the more you have them on it. We want other therapies. That's why I'm excited about all these other things.
We'll try to spread out the dosing. We'll try to
Yeah,
lower it
exactly.
as long as they're really controlled. But like you mentioned, a lot of these patients, that's the only thing that works.
Right.
All right. Thank you very much, Dave.
Yep. Sure.